Rules Committee come to order, and good morning, and welcome to the Rules Committee. Today, the committee will consider H.R. 1628, the American Health Care Act of 2017. On March the 20th, 2010, the Rules Committee met in this very same room, of which I was a part of that meeting, and passed the Senate-crafted language in a House shell bill that will ultimately destruct and devastate our nation's health care system. The American people were promised by the President of the United States, who was so supportive of the bill that it even eventually took his own name. And his party and the bill would lower premiums by $2,500 per family per year. He promised the American people that if they liked their doctor, they could keep their doctor. He promised the American people that if they liked their health care plan, they could keep that also. He promised the American people that no family making less than $250,000 a year would see any form of tax increase when he became president. He promised the American people that Obamacare would mean more choice, more competition, and lower costs for millions of Americans. Now, 7 years later, almost to the day, it is abundantly clear that this Affordable Care Act, known as Obamacare, has failed the American people and the health care system and the people it was designed to help the most. As to the promises, premiums have increased by an average of 25% this year alone on the Obamacare exchanges, ruining the pocketbooks of American families and a far cry from the $2,500 reduction that they were promised for each family. At least 4.7 million Americans have been kicked off their preferred health care plans and had their coverage canceled due to Obamacare law. Despite the promise that if you liked your plan, you could keep your plan, and if you liked your doctor, you could keep your doctor. Obamacare contained $1 trillion in new taxes, mostly falling on families and job creators. Additionally, 18 of the 23 Obamacare co-ops have failed, costing taxpayers nearly $1.9 billion and forcing patients to have to scurry to find new alternatives for their health care. Obamacare has forced employees and employers to not only cut and lose their jobs, but to lay off employees now on a track that hurts American workers and their hours, an equivalent of at least 2 million jobs being lost. Simply put, Obamacare is collapsing right before the American people's eyes. Options and choices are disappearing for consumers, and an anti-competitive government-run market has been created that is leaving American patients, families, and business across this country desperate for answers. Nearly one-third of the United States counties currently have only one insurer offering exchange plans, and quite frankly, it is getting worse. That is not competition, and that's a government-run monopoly. Doctors also need a change. Patients need a change. Families need a change, and the American people are demanding a change, especially when they went to the ballot box in November. H.R. 1628, the American Health Care Act of 2017, eliminates Washington's one-size-fits-all health care plan. It dismantles the Obamacare taxes. It eliminates the individual employer mandates. It prohibits health insurers from denying coverage and helps young adults across the country to have access to health care while stabilizing and restoring a free market for all Americans. Most importantly, this legislation empowers individuals and families to make their own health care decisions. It helps low and middle-income families across the country to have affordable quality care by providing monthly tax benefit that ensures parity to an unequal today marketplace. Americans deserve a competitive insurance marketplace that provides quality care at an affordable cost. For that reason, I'd like to welcome really the gentlemen and gentle ladies who have been a part of the development of this plan, the architects of this legislation. From Hood River, Oregon, the gentleman Greg Walden, the chairman of the Energy and Commerce Committee, the gentleman from Texas, Montgomery County, Texas, Kevin Brady, who I came to Congress with, and the gentlewoman, Congressman Diane Black from Tennessee. Chairwoman, we're delighted that you're able to join us this morning on this first panel, as well as their ranking members. Thank you for being here today to complete our promise to the American people. I'd also like to welcome their panel of ranking members who are no strangers to the Rules Committee for their time before us. Obviously, the gentleman, Mr. Yarmouth, the gentleman, Mr. Pallone, the gentleman, Mr. Neal. Without objection to anything any of you have in writing will be entered to the record. Before I yield to the gentleman from Hood River, Oregon, I would like to defer to the ranking member of this committee, the gentleman from Massachusetts. And let me say this, our colleague and gentlewoman, Mrs. Slaughter, who is the long-term member of this committee and actually the ranking member, is still in the hospital, not feeling as well. Chest colds are tough when you live in Syracuse, New York. And I want us to know that we could still and should keep her in our prayers. But I called her yesterday. She can't wait to get back. She can't wait to get her hands on me, on the bill. But the spirit that Mrs. Slaughter, Louise Slaughter, has brought to this committee, the spirit of which she represents her party and ideas, not just from Syracuse, New York, but really across this country, is amazing. And I'm going to miss her today, and I want us to know that she'll be back shortly, and she promises to be full of vinegar and a lot of words. So before we go too far, I'd like to go back to the ranking member. Louise, we miss you. Hope you're listening today. And the gentleman from Massachusetts recognized.
Well, thank you, Mr. Chairman. And I talked to Louise this morning, and I assure you she's watching all of us today and taking notes. But, Mr. Chairman, before I begin my opening statement, I would like to ask a question. It's the same question I asked last night, and that is whether or not we've received an updated CBO score that takes into account the several managers' amendments that we received last night and Monday night.
That's a good question, and I'm going to give the same answer that I gave probably at least once or twice up at the Rules Committee and once on the floor, and that is the Congressional Budget Office is made up of professionals who are trying to get as close to the answer as possible. That it does me no good to try and tell them their answer nor their time frame. They have an order that they're attempting to get placed right now. And in fact, the gentleman, Mr. Brady, who is the chairman of the Ways and Means Committee, has indicated publicly that we will not go to the floor without that CBO score. And with the answer that I have given is that we fully anticipated it sometime in the early evening or the evening tonight. So as we go through this, I would say that there will be a chance for the gentleman, Mr. Brady, or the gentleman, Mr. Walden, or the gentlewoman, Chairman Black, to forthrightly address that, to make any corrections to my assertions that I make today, with the knowledge that Diane does not mind correcting me probably on a regular basis.
Well, does that mean we won't report a rule out for consideration of the bill?
You know what? I'm going to let us get the real answer, because what I gave was an answer about a day and a half ago. I don't know what the current mark is yet. I know Ray Baum, who is the staff director for Mr. Walden, has a direct line to CBO in as much as being able to just get the next guess, and we will get that back to you.
Well, and the reason why I ask is because the last CBO estimates show that this bill would kick 24 million people off of their health insurance. And the Brookings Institution said that the manager's amendments are unlikely to reduce the number of people CBO estimates will be pushed off their health plans. And in fact, and I quote, they say it is possible that its revised estimate could be somewhat higher. So, Mr. Chairman, I appreciate your answer, but it strikes me as odd that we are proceeding without all the information. And I see a woman sitting in the audience here with a T-shirt that says, "What's the rush?" I don't know why we just don't wait to consider this bill until we have all the information. And given that fact, I feel very strongly about that. I don't think we should be meeting on a bill when we don't even know how many people will hurt. And so, Mr. Chairman, I move that the committee adjourn until we receive a revised CBO estimate.
I second that motion.
Thank you very much. There's a motion on the floor. The motion is to adjourn. Do we have any discussion? Does anyone wish to discuss this?
Yes, I do, Mr. Chairman.
Gentleman's recognized.
Mr. Chairman, Mr. McGovern makes the point, and I find it disconcerting that we're going to proceed here today, hearkening back, at least you and my dear friend from Oklahoma were here when the Democrats passed their measure. And there was a lot of discussion. I remember Dr. Burgess, who is not here, but I remember him railing actively about the fact that we didn't have the CBO score. Now, logic dictates that if the Congressional Budget Office has said 24 million people, and footnote right there, I keep hearing arguments. Some people say it's 24 million, other people say it's 14, some say it's 12. One is too many, and that needs to be clearly understood. This is a country where everybody has the right, I believe, to have insurance. So I guess ultimately, I don't think we can blame CBO when you keep changing the rules. And the question that I have for you is the manager's amendment already scored? And I'll ask Congresswoman Chair Black this question when you're doing your work. Is that manager's amendment scored? And since you're having difficulty getting to 216, are there other things that are going to cause the CBO score to change when you add or detract things in order to sweeten it for members to be able to vote for the measure? This is very disconcerting. We did not proceed this way. We did do things, I think, substantially more hearings, a considerable amount of more input, and at the very same time, when we did get to this stage, we had the congressional budget score, and I think it's critical.
Thank you very much.
Thank you,
We'll now
Mr. Chair.
move to the motion. The motion is to adjourn. Those in favor signify by saying aye.
Aye.
Those opposed, no. No. Noes have it, noes have it.
As for roll call, Mr.
Gentleman asks for a roll call vote. The clerk will poll the committee.
Mr. Cole? No. Mr. Cole, no. Mr. Woodall? No. Mr. Woodall, no. Mr. Burgess? Mr. Collins? No. Mr. Collins, no. Mr. Byrne? No. Mr. Byrne, no. Mr. Newhouse? No. Mr. Newhouse, no. Mr. Buck? Ms. Cheney? No. Ms. Cheney, no. Ms. Slaughter? Mr. McGovern?
Aye.
Mr. McGovern, aye. Mr. Hastings?
Yes.
Mr. Hastings, aye. Mr. Polis? Mr. Chairman?
No.
Mr. Chairman, no.
Clerk will report the total.
2 yeas, 8 nays.
I'm sorry, could the clerk
Sorry,
please
sir.
report the totals?
2 yeas, 7 nays.
The motion's not agreed to. I would like to, if I could, just state so that we're kind of able to get a clearer understanding, as many members of Congress were not here. Charlie Rangel, the chairman of the Ways and Means Committee, that day when I asked him about the CBO score, said one was not necessary. It wasn't like they didn't have it prepared. It was unnecessary because, Mr. Sessions, it will add millions and millions of jobs. It'll be the greatest single job creation bill ever passed by the Congress. That's a little bit different and a far cry from the story that's being told today, now 7 years later. Secondly, I hope that we're able to ascertain the difference between the CBO said there may be some number of people who are not covered versus being kicked off their health care plan. I believe the testimony today from our three witnesses will reveal that we don't really anticipate anybody being kicked off their plan, unlike the 4.7 million people who were kicked off their plan by Obamacare. So there's still 30 million people who are uninsured in this country today, I believe that number of uninsured will go down, and I believe that is what should have been said by the CBO. We're delighted that each of you are here.
Okay, do I get to give my opening
The
statement?
gentleman would be allowed to
All right, thank
complete
you.
that.
Yeah.
Yes, sir.
So, good morning. And I hope everybody fueled up on coffee and donuts. And I want to thank the rules staff for getting Dunkin' Donuts coffee from Massachusetts. It's the best coffee in the world because we've got a lot to say about this bill, and none of it is good. First, let me just lay out what the bill actually is. It is a massive tax cut for millionaires and billionaires paid for by taking health insurance away from 24 million people, period. Anyone who takes 5 minutes to look at any unbiased analysis of the bill knows that this is true. Massive tax cuts for the well-off at the expense of 24 million people. And sometimes I think my Republican friends have lost their human ability to feel what 24 million people really means. So let me paint a picture of how big that number is. 24 million people is basically the entire population of the country of Australia. It is more people than live in the states of Kansas, New Mexico, Nebraska, West Virginia, Idaho, Hawaii, New Hampshire, Maine, Rhode Island, Montana, Delaware, South Dakota, North Dakota, Alaska, Vermont, Wyoming, and the District of Columbia combined. You know how I know this bill is a tax giveaway for the wealthy and not a health care bill? Because according to the nonpartisan Congressional Budget Office analysis, and this is truly incredible, it would actually result in more people being uninsured than if the Affordable Care Act were simply repealed. Let that sink in for a minute. Second, this bill will cause people to pay more out-of-pocket dollars for lower quality health insurance. You're asking people to pay more for less coverage. In particular, lower income and older Americans will see their costs skyrocket. Those people who can least afford to pay more. Third, and this is a big one, this bill guts Medicaid and Medicare. Don't take it from me. The AARP said, and I quote, "This bill would weaken Medicare's fiscal sustainability, dramatically increase health care costs for Americans aged 50 to 64, and put at risk the health care of millions of children and adults with disabilities and poor seniors who depend on the Medicaid program for long-term services and supports other benefits," end quote. In fact, Americans aged 50 to 64 will pay premiums 5 times higher than what others pay for health coverage, no matter how healthy they are. This bill is an age tax, plain and simple. And you're cutting $880 billion from Medicaid. That's a 25% cut in funding. All this to give tax cuts to the rich and to corporations. The bill must look like a cruel joke to the most vulnerable among us. Representative Mo Brooks, a member of the Republican conference, said just last night, and I quote, "Quite frankly, I'm persuaded that this Republican health care bill, long-term, is a detriment to the future of the United States of America," end quote. Finally, this process is horrendous. The Republican majority rushed their bill through the committee process without any hearings, just holding marathon markups where no Democratic amendments were accepted. They didn't even wait for a CBO score. Then when the score finally came, it showed the bill would kick 24 million people off their insurance. Did they stop then? No, of course not. We're still full steam ahead, only now we have a cobbled-together manager's amendment. I'm sorry, we have 4 cobbled-together manager's amendments, since the originals had errors, and again, no CBO score. Didn't you learn your lesson last week? Even worse, this manager's amendment, which we received just 36 hours ago, is full of backroom deals like the Buffalo bribe, a cynical agreement with wavering New York Republicans who know the Republican health care plan would devastate New York. And now they're saying, don't worry, if you don't like this bill, it's just it's just step 1 of 3. You'll get another chance to vote on health care during step 3. Never mind that they can't give us the full slate of bills that are part of this mysterious step 3. Or maybe I should just take Senator Cotton's word for it. And he said, and I quote, "There is no 3-step plan. This is just political talk. It's just politicians engaging in spin," end quote. Ted Cruz from your state, Mr. Chairman, called the third prong of this 3-bucket strategy, quote, the sucker's bucket, end quote. The sucker's bucket. So please, slow down. Think about what you're doing. Don't jam this disastrous bill through the House with patched-up fixes. Wait for a revised CBO score. Listen to what members of your own conference are saying. Or better yet, don't do this at all. It's clear that you never really had a plan to replace the Affordable Care Act. Don't pretend you did and then make our most vulnerable pay the consequences. This is a lousy bill. This is a lousy process. And quite frankly, we should not be considering in this committee. I thank the chairman, and I yield back my time.
Thank you very much. We appreciate the gentleman's opening statement and comments related to that. And we now turn to the 6 witnesses that we have. Ladies and gentlemen, what we're going to do is go through a very disciplined, straightforward process here, and that is I'm going to first acknowledge the gentleman from Hood River, Oregon, the chairman of the Energy and Commerce Committee, and then I'm going to go to the gentleman from Texas and let him explain his part. And then, Ms. Black, I'm going to let you do your part. Then we're going to go through and do the same, where we will go to Mr. Pallone, we'll go to Mr. Neal, and we will go to Mr. Yarmouth. I want you to know that this committee has attempted to do our homework, but we're here to listen also, and listening is an art that our members have gotten very good at, and so we want to make sure that as you speak, that please remember that microphone needs to be as close as it can to you. This is a difficult room, and that the green light is turned on, and the gentleman from Hood River, Oregon is now thanked for being here, and the gentleman's recognized.
I thank the chairman, and I first want to concur in your thoughts about Ms. Slaughter. She lives just up the street from my little place here in Washington, D.C. She is a fierce fighter for the liberal side of the Democrat Party, and we wish her full health and quick recovery. Additionally, Mr. Chairman, I want to wish you happy birthday. Can't think of a better place to spend it than right here with you.
Yeah. And it's 50 again, Mr. Walden.
It's not every day you turn 50, and today's not that day
And
either.
you know, the gentleman,
But I'm glad
gentleman
to be
to
here.
your right's getting ready to have a birthday, around here too, so don't forget the gentleman, Mr. Chairman Brady.
That's right.
I'm going to throw you on, well.
Well, we appreciate the opportunity, Mr. Chairman, and I know your committee members have questions. They have a lot of interest in this bill. Many have participated in its crafting. So if you'll indulge me, I'll walk through it in detail, so to answer as many questions as possible in advance. First, I want you to know that the Energy and Commerce Committee has convened 31 oversights on the Affordable Care Act, oversight hearings on the Affordable Care Act. The Subcommittee on Oversight and Investigations convened 18 hearings. The Subcommittee on Health convened 9. The Oversight and Investigations and Health Subcommittee convened 1 joint hearing. The full committee convened 3 hearings over the last several years to look at what was working, look at what wasn't working. And as you know, the Congress, in a bipartisan way on multiple occasions, sent President Obama legislation to repeal parts of Obamacare that were not working. And he signed 20 of those into law. 4,775 votes of those folks voting to make changes in Obamacare came from the Democrats. So even Democrats have recognized there are problems with Obamacare that needed to be fixed. We've had 107 witnesses testify before the committee during that multi-year process. 38 of those were administration witnesses. The committee released 5 investigative reports in the 114th Congress, including 59 findings and 9 recommendations. All of that work over the last several years has brought us to this point. First, let me describe the bill. This bill prohibits health insurers from denying coverage or charging more money to patients based on pre-existing conditions. This is something we've heard from both sides. I hear it at home. I believe it fully, that just because you've been stricken with a health disease should not preclude you from being able to get insurance you can afford. So we kept in place provisions making sure that people could not be denied insurance because they have a pre-existing health care condition. Second, our plan helps young adults gain access to health insurance and stabilizes the marketplace by allowing dependents to continue staying on their parents' plans until they're 26 years of age. This was a Republican idea that existed before there was an Obamacare, and it's something we feel strongly about. Our plan proposes a new patient protection for patients who maintain continuous coverage. Similar continuous coverage protections have already existed for the vast majority of Americans who get their insurance through their employers. It's similar to what is also done in Medicare Part B and Medicare Part D. So we build on those successful provisions to make sure that continuous coverage protections remain. When patients wait until they're sick to seek coverage, it disrupts the entire marketplace, so it's unfair to everyone else. Continuous coverage protections incentivize patients to get and keep health care coverage. In our plan, this protection would apply to patients in the individual and small group market as well. So these are new protections. Continuous coverage protections will protect those with pre-existing conditions, guaranteeing, Mr. Chairman, access to coverage, prohibiting benefit exclusions, and banning premium rating based off of health status. So they can't jack up your health care prices for your insurance because you have a pre-existing condition. Extending these protections to the individual and small group market is a simple but important reform that will encourage patients to enroll in coverage and stay enrolled. Now, some may suggest continuous coverage would lead to higher premiums based off of health status and pre-existing conditions. I think we've heard those false charges. They are false. Our plan would guarantee access to coverage, prohibit pre-existing condition exclusions, ban premium rating based solely off of health status, as well as other important patient protections. This new safeguard applies to everyone who remains enrolled in a health insurance plan, whether that individual is switching from employer-based health care to the individual market or within the individual market. The employer market already has a definition of continuous coverage that allows for gaps of up to 63 days, so you have time in between. Right now, plans share information to certify and disclose if any applicant has maintained continuous coverage. We would bring this same standard to the individual market. It's long overdue. Again, Medicare Parts B and D have similar basic continuous coverage frameworks. To prevent individuals from gaming the system and lower premiums for everyone as a result, our plan allows for a flat surcharge on top of patients' base premium until they reach continuous coverage status. So we take those out of the system that would game it and say you have to be responsible and maintain continuous coverage. Our plan would protect patients living paycheck to paycheck, giving them a hardship exemption if they're unable to pay a 1 month's premium. As long as patients catch up on their payments, they would not lose this important continuous coverage protection. We envision one open door, one enrollment, so patients without continuous coverage status are not treated unfairly for something that's previously not been in the law. To attract younger enrollees, individuals coming off dependent coverage, we're talking about those potentially 26 years old getting into 27, are allowed a 1-year grace period since it would be their first year as an active purchaser. And if an individual experiences a qualifying life event, he or she would not be charged more than the standard rates, even if they're dealing with a serious medical issue. So we protect people with pre-existing conditions. We take those few people who are gaming the system and make them act more responsibly, and we provide for continuous coverage. These are very important principles contained in this law. Medicaid. Our plan refocuses Medicaid's limited resources to the patients most in need, Mr. Chairman. We're talking about the low-income adults, children, pregnant women, elderly adults, people with disabilities. We do that by responsibly unwinding the Medicaid expansion, by our freezing new enrollment in Obamacare's expansion, and grandfather those existing enrollees. We put Medicaid on a sustainable budget with per capita allotments, and we empower states with new freedoms and flexibilities to run their Medicaid programs. Look, Medicaid is a critically important program. It represents a partnership between the federal and state governments to traditionally provide benefits to eligible low-income adults, children, pregnant women, elderly adults, people with disabilities. This is a state and federal partnership. Medicaid currently covers more than 70 million of our fellow citizens. For more than a decade, the Government Accountability Office, however, has told Congress that Medicaid is a high-risk program. High-risk program. In 2018, total Medicaid spending will be larger than our nation's defense budget. By the end of the decade, total Medicaid spending will cost taxpayers $1 trillion. Last year alone, the GAO reported there were $36.3 billion in improper payments in Medicaid. I've met with GAO. They've testified before our committee. This is a problem that must be addressed because that $36.3 billion should be going to help those most in need, not going out to improper payments. This is just not a fiscal issue. It's an issue that jeopardizes the ability of federal and state governments to take care of the most vulnerable among us who rely on this program. We need to put Medicaid on a budget and give states greater flexibility to manage the program to best benefit their citizens. Obamacare forced states to expand Medicaid to cover able-bodied adults or lose their federal Medicaid funding. After the Supreme Court's 2012 ruling in the NFIB versus Sebelius case that this requirement was unconstitutional, Mr. Chairman, some states still chose to expand Medicaid eligibility to people under the age of 65 with income up to 138% of the federal poverty level. Obamacare also provided enhanced federal funding for expansion, and the federal government covering 100% of the costs through 2016. In 2017, the federal government pays 95 cents on the dollar for each expanded enrollee. And that amount gradually diminishes to 90% under President Obama's plan by 2020. Now, this policy creates a gross inequity in the law because the federal government, think about this, Mr. Chairman, covers a higher percentage of the cost of care for able-bodied adults than it does for people in poverty who are disabled, elderly, or children below the poverty level. Our plan will not pull the rug out from anyone. For 2017, 2018, and 2019, states with Medicaid expansion enrollees can continue to receive the enhanced federal match available under current law for these enrollees. Individuals who are Medicaid expansion enrollees could remain enrolled as long as the state kept the program and they otherwise remain eligible, and they would continue to receive that enhanced match, that 90% match. So if you're on it today, you're on it tomorrow, you can stay on it until you no longer qualify for Medicaid, because maybe you got a job that pays you a lot more and you're no longer eligible and you get your insurance through your employer. This grandfathered population expansion enrollees, we believe, and CBO believes, will leave the Medicaid rolls at some point as they naturally move up. On or after January 1 of 2020, if a state with Medicaid expansion keeps the expansion, individuals otherwise eligible for the expansion program could still enroll in the program. However, for any new Medicaid expansion enrollee, the state's expenditures for such person would be matched by the state's regular Medicaid match rate. So that ranges somewhere between 50% and 83%, I believe, is the range there. Oregon's about 63%. So those people who are now at getting a higher rate, the able-bodied adults, they could still be added, but they would just be matched at a lower rate. We're asking our partners, the states, to step up to help keep these people on. The plan also provides $100 billion to design programs that meet the unique needs of patient populations and low-income Americans. This is, I think, a really important facet of this is the $100 billion patient and state stability fund, which I'll get into in just a minute, because I know you want me to get into detail in these issues. So we propose a per capita allotment to determine a fair level of funding for states based on the number of enrollees in each unique Medicaid population. This type of allotment has been supported by members of both parties, Mr. Chairman, not just by Republicans, but also by key Democrats, including former President Bill Clinton, former Vice President Joe Biden, former Secretary of State John Kerry, former Senate Majority Leader Harry Reid. They all supported per capita allotments a number of years ago as an appropriate means to manage Medicaid going forward. A per capita allotment reform protects the individual entitlement and does not change Medicaid rules regarding access to care. Specifically, our per capita reforms proposed in this legislation do not alter general eligibility standards and pathways, so you can still get on under the same ways. We do not alter protections. We believe in them for the disabled, the elderly, and children. The requirement that states pay their fair share under the federal medical assistance percentage, that's their FMAP matching rate. We do not alter coordinating with exchanges and individual market coverage. We don't change the Children's Health Insurance Program, which we believe is very important and our committee will take up and reauthorize later this year. Coordination efforts for individuals who are duly enrolled in Medicare and Medicaid, requirements related to program integrity and transparency, and current efforts to improve the quality of care and delivery systems. Let's talk about flexibility, Mr. Chairman, because this is important. We can do some things in this legislation, as you know. There are many other things that Secretary Price should be able to do through authorities granted to the Health and Human Services Secretary under federal law. Under our plan, states would receive federal funding allotments for each of the major beneficiary categories: aged, blind, disabled, children, and adults. And it would be based on the number of enrollees in each of these categories in their states. A state's total allowable allotment would be calculated as the sum of the total number of people, the enrollees, across these eligibility groups. So you take what they're getting, what they're paying, and that against the population. This formula would represent the total amount of federal funding for which a state would be eligible to receive federal matching funds. This total computable approach provides flexibility to governors and state leaders in implementing the policy. Importantly, a per capita allotment is not a limit on funding for an individual Medicaid beneficiary. It doesn't say you as an individual has this amount. It is a total summation, and then some people will cost more, some will cost less. The states are able to manage their programs accordingly. If an individual's care provided to be more expensive than average, federal funding could continue to be used to pay for it as long as the state as a whole didn't exceed the sum. Our plan would make additional common sense reforms to Medicaid, including something our Oversight and Investigation Subcommittee and Health Subcommittee looked at under Dr. Burgess, and that is lottery winners who win. There aren't a lot of these, by the way, but there are some. It's been brought to our attention by states and our colleagues. There are cases where you win the lottery and you get to stay on Medicaid because they don't count the winnings today. We don't think that's fair, so we take care of that in this legislation. While it's not possible to get all the flexibility states may desire through the expedited process, the budget reconciliation, working with the Trump administration, states will have the ability to seek additional flexibility through their programs. Mr. Chairman, we're making a lot of changes in the law, and I know this is important to you, so let me conclude with a description of the State Patient Stability Fund. In order to stabilize health markets damaged by the current law and to ensure all Americans have access to affordable health care, states need well-functioning and stable marketplaces that encourage and incentivize patients to get covered and stay covered. Both the Patient and State Stability Fund and introducing age rating reform will give states the flexibility to bring down health care costs and strengthen the market. So let me start with the Patient Stability Fund, Mr. Chairman, because I know this is important. Our plan provides a solution to help repair the insurance market by providing more affordable coverage options to consumers. The Patient and State Stability Fund. This fund will help states lower the cost of care for some of their most vulnerable patients. This bill provides $100 billion, Mr. Chairman, to design programs that meet the unique needs of patient populations and help low-income Americans afford their health care. Before Obamacare, state-specific high-risk pools were program-specific, limiting the flexibility of innovation that local officials could use to meet the unique needs of diverse communities. We want states to be the great innovators that we know they have been, they want to be, and they can be. So the Patient and State Stability Fund would give states flexibility in program design. They could use the money, by the way, in this fund to cut out-of-pocket costs, like premiums and deductibles. We all care about what those costs are to the people we represent. So we have a fund here that will allow states to access money. And then, by the way, that starts in 2018. That doesn't wait until 2020 or 2021. So some of the same subsidies that are there today will continue, but also be augmented initially by this fund right away. So they can do a lot in the meantime to fix this marketplace. They can arrange partnerships with healthcare providers to support their efforts to provide care. They can help with high-risk individuals without access to employer-sponsored coverage across coverage in the individual market, or access coverage in the individual market. They can provide incentives to appropriate entities to help a state stabilize premiums in the non-group market. They could reduce the cost of providing health insurance coverage in the individual and small group markets for high-cost individuals. They could promote participation in the non-group and small group markets and increase options that are available. We're about giving people new options, better options, and helping on the affordability piece. And we can promote access to preventive services, dental or vision care services, or the prevention, treatment, and recovery for individuals with mental or substance abuse disorders. This is important to all of us. We made sure these funds would be available for that purpose. And by the way, on the latter part of this is in addition to what Congress did at the end of last year to address issues of mental health and substance abuse. We put $1 billion in to deal with opioid abuse. And so these are in addition to that and pay health care providers. So, Mr. Chairman, we've got a lot more to talk about. I know you have other witnesses. I appreciate the time to get this far into the presentation. We believe we're going to give people new choices and better choices. We think we will far outperform what CBO says, and that we can restore this market before it collapses if we act now. if we act now. So, Mr. Chairman, I yield back the balance of my time. I look forward to hearing from your members and further discussing this very important piece of legislation.
Thank you very much, Chairman Walden. Chairman Brady, welcome to the Rules Committee. We're delighted that you're here and the gentleman's recognized.
Thank you, Chairman Sessions, ranking members, members of the Rules Committee. Thank you for allowing me to testify in support of the American. Welcome. Thank you for having me. And thanks for allowing me to testify in support of the American Health Care Act. And thank you for your consideration of this important legislation to repeal and replace the Affordable Care Act. The Affordable Care Act, also known as Obamacare, has been one failed promise after another. The fact is this law has hurt far more Americans than it's helped. Millions of Americans have lost access to the health plans and doctors of their choice. Out-of-pocket costs are just skyrocketing. And free market competition in healthcare has all but disappeared. With the American Health Care Act, we have the best opportunity in 7 years to repeal this sinking ship of Obamacare, clear the deck, and begin our step-by-step process to deliver a healthcare system that truly works for the American people. President Trump has called on Congress to take decisive action now on healthcare reform. This legislation answers the President's call to action in a thoughtful, deliberate way that Americans truly deserve. The Ways and Means portion of the American Health Care Act is focused on achieving two important priorities. First, delivering swift relief to the American people by repealing Obamacare's most harmful provisions. We end the individual mandate tax penalty has forced millions of Americans into plans they do not want and cannot afford. We end the employer mandate tax penalty, which has burdened our local businesses and made it harder for them to grow their companies, to hire new workers, and raise wages. And we repeal Obamacare tax hikes that have driven up costs for the American people and reduced access to high-quality care. Our second priority with this legislation is to deliver on our promises to replace Obamacare with patient-focused solutions that truly expand choice, that lower costs, and enhance competition. Here, we are taking action to reclaim control of health care from Washington and put it back where it belongs, with patients, with families, and with states. We expand health savings accounts and make them more flexible and user-friendly. This will give patients and families much greater freedom to save their health care dollars for the future and spend them as they see fit. We protect health coverage for the more than 150 million Americans who receive it at work. And for low and middle income Americans who don't receive coverage through work or a federal program, we offer an advanceable refundable tax credit that people can use immediately to help purchase coverage that works best for them, not Washington. These tax credits provide a much better free market alternative to the inefficient Obamacare subsidies that exist today. They will deliver support to low and middle income Americans while also encouraging greater competition and greater innovation in the health insurance market. And with greater competition, there will be more choices for the American people, lower costs, and better coverage that's tailored to the needs of patients and families, not Washington. Finally, to further ensure the American Health Care Act accomplishes these important priorities for the American people, I would ask the Rules Committee to make an order the manager's amendments to the bill. These amendments, which were made public on Monday evening, followed by an additional second-degree technical amendment yesterday to correct drafting errors, take important actions to strengthen the American Health Care Act. They will better ensure that all Americans have the help they need to access the care, again, that's right for them. Specifically, they will provide an additional $85 billion in tax relief by further reducing the medical expense deduction threshold for Americans with high health care expenses, many of them in the 50 to 64-year-old range. Just last year, AARP supported a similar bill lowering the threshold for pre-Obamacare levels. According to AARP, quote, for the approximately 8 to 10 million Americans who annually take this deduction, it provides important tax relief which helps offset the costs of chronic medical conditions as well as long-term care, unquote. This new tax relief creates new resources available to the Senate to provide assistance, including enhancing the tax credit to older Americans who purchase insurance in the individual market. In combination with the age-based tax credit and the Patient and State Stability Fund, which provides $100 billion to to states to help targeted populations. This change reinforces the commitment of House Republicans to ensure Americans of all ages have access to patient-centered health insurance. Furthermore, these manager amendments will provide more immediate relief from Obamacare's burdensome taxes on families and our local businesses, moving up the date of their repeal from 2018 to this year, 2017. They will strengthen protection for the right to life by ensuring that only the amount of the tax credit that is needed to cover the premiums is used, rather than allowing the excess to roll over into a health savings account. This further ensures federal dollars cannot be used for abortion services. And finally, they'll help guarantee that this legislation meets our reconciliation requirements so that it can maintain privileged status in the Senate and move quickly to the President's desk. In closing, I want to thank Chairman Walden and Chairman Black for your leadership on the American Health Care Act. And again, I want to thank the Rules Committee for your consideration of this important legislation. Mr. Chairman, I look forward to taking your questions, and I yield back.
Chairman Brady, thank you very much. Chairman Black, welcome to the Rules Committee. We're delighted that you're here. I know that you are showing up with your ranking member who is ably up to the task also, and we're going to welcome you at this time.
Thank you, Mr. Chairman.
Yes,
Good
ma'am.
morning to all you and all the members of the committee, and especially to my ranking member of the committee. I want to thank you for this opportunity to speak here today, and I come before you to discuss the 1628 American Health Care Act of 2017. The American Health Care Act is the first step in our efforts toward patient-centered health care reform. The bill seeks to give American people freedom and choice in their health care decisions. It gets government out of the relationship between patients and their doctors and puts people back in charge of their own health care. And it brings the free market principle of competition to an industry that has long been dominated by government intervention. We are united in our goal to repeal Obamacare and replace it with a patient-centered health care. Right now, Obamacare is imploding. We were promised the premiums would decrease by $2,500, and instead, average family premiums in the employer market soared by $4,300. We were promised that health care costs would go down. Instead, we see deductibles have skyrocketed. We were promised that we could keep our doctor and our health care plans. Instead, millions of Americans have lost their insurance and the doctors that they liked. In short, the Affordable Care Act was neither affordable nor did it provide the quality of care that the American people deserve. Last week, the House Budget Committee favorably reported that the American Health Care Act to the full House of Representatives for their consideration. Our markup was filled with lively debate, and I applaud our members for working to make this bill better. There was concern from members of my committee that this bill did not reflect a strong enough conservative vision for the health care reform, and I joined them in that concern. The Budget Committee approved 4 motions to be recommended to this committee and the full House as it laid out in our report. These motions describe potential changes that would address our concerns, including, number 1, greater state flexibility in the design of their Medicaid programs. Number 2, minimizing the new Medicaid enrollment by able-bodied adults. Number 3, promoting work requirements in the state Medicaid programs. And number 4, ensuring that tax credits are targeted to those individuals who need them most. The manager's amendment submitted this week includes changes advocated by our committee. This is the way the legislative process is supposed to work, and I applaud my colleagues for staying in the fight and making sure that we pass a bill that truly reflects our values. It goes a long way towards resolving some of the conflict and disagreement within our conference and addressing the concerns of my committee. It is a step in the right direction, and I urge the members of this committee to support it. We have a once-in-a-generation opportunity to reform health care with a free market principles in the driver's seat, not government. It's our opportunity that we cannot let pass by. As this bill continues to better reflect our patient-centered vision of health care, we will soon be faced with a stark choice. The choice is between repealing and replacing Obamacare and voting to keep Obamacare status quo. And while no legislation is perfect, this bill does accomplish some of those important reforms. It zeroes out the mandates. It repeals taxes, and it repeals subsidies. It allows people to choose the health care insurance plans to meet their unique needs of their families instead of purchasing a one-size-fits-all plan that has been mandated by Washington bureaucrats. And it modernizes Medicaid, a once-in-a-lifetime entitlement reform. Ending Medicaid's open-ended funding structure will play an important role in addressing the future budget deficits and our growing national debt. Put simply, this is a good first step, but it's only a first step. My good friend and our former colleague, Dr. Tom Price, will use his position as the Secretary of Health and Human Services to address some of the regulatory burden of Obamacare through the administrative action. And we will vote soon on individual pieces of legislation to implement even more patient-centered free market reforms that we cannot address through reconciliation. This is a three-pronged process, and we're taking to rescue the American people from a damaged Obamacare that has done to our economy and our health care system. But as we talk about our work to repeal Obamacare and replace it with patient-centered reforms, we also have to remember that the problems with Obamacare are not merely numbers on a page. I've been a nurse for more than 45 years, and I saw the impact in the 1990s of a government-run single-payer healthcare system that we had in the state of Tennessee called TennCare. It was a pilot project. I saw costs rise and quality of care fall. It's what inspired me to get involved in the public service sector to begin with. And when I saw some of the broken principles applied to healthcare on the national level with Obamacare, I felt compelled to bring my voice and my experience here to Congress, having experienced this previously. I get calls every day in my office, and I'm sure that many of you do as well, saying, please help us, rescue us. Premiums in my state have skyrocketed. There are actually parts of Tennessee that don't have a single insurance provider in the marketplace, not one. While in other parts of my state, people may have an insurance card, but they can't get care. They actually are going to health departments even though they have an insurance card. We must work together on a conservative vision for repealing and replacing Obamacare. It's a promise that we made to our voters for years, and it's a promise we finally have an opportunity to keep, and I intend to keep that promise. I urge all members to work toward a common goal, and with that, I look forward to answering your questions.
Madam Chairman, thank you very much. As I previously indicated, I'm going to attempt to go now in order with our colleagues that are here as ranking members, and the gentleman from New Jersey, Mr. Pallone, would be acknowledged. And we didn't spill anything there, did we? It's all okay? Okay. Gentleman's recognized.
Thank you, Mr. Chairman. I would like to respond, I would like to start, I should say, by responding to some of the things that my colleagues on the Republican side have said. And I'm not doing that because of any personal reason. It's just that I feel that, you know, when we put together the Affordable Care Act, when the Democrats did 7 years ago, and I was part of that, we were responding to what we thought was a crisis in the healthcare system, in the sense that more and more people did not have health insurance. Oftentimes their health insurance was lousy, it was skeletal, didn't provide much in the way of benefits, and premiums and costs out of pocket were continuing to go up, double digit for the most part every year. And so I think that we put in place something that we believe addressed that. You know, the number of people that are uninsured has gone down considerably. Something like 95% of Americans now have insurance. We believe the quality of care has improved. We don't have the double-digit inflation for the most part. There may be some areas where there is a significant cost increase, but for the most part, costs have slowed. They're in the single digits, even the lower single digits for the most part. So I feel that when you come along as Republicans and say that you want to repeal this, the burden is on you to say why it's going to be better, because we think that we have created a much better system. And so in response to my own chairman of the Energy and Commerce Committee, Chairman Walden, I just wanted to say a number of things. First of all, he mentioned hearings, but there were no hearings on this bill. This bill was given to us, I think, maybe 2 days, the Monday, and then we started the the markup on Wednesday. There has still never been a hearing in the Energy and Commerce Committee on this bill. And Speaker Ryan said there was going to be regular order. There was not regular order by any imagination, frankly. Also, I think that it's significant that my colleague, Chairman Walden, talked about the fact that many parts of the ACA are not repealed. Pre-existing conditions, all the discriminatory practices that existed before. So I do want to thank, I know there's not much mention of it, but thank us on the Democratic side for actually putting together something that, for the most part, you're not repealing, okay? But unfortunately, the things you are repealing are the things that I think are the most important, and that is people's ability to afford coverage and people's ability to pay for their coverage. The biggest problem right now, because Chairman Walden keeps talking about guaranteed access to me is nothing if you can't afford your premium. It's nothing if you have insurance, but you can't get health care because deductibles or copays are too high, and you have to pay more out of pocket. So I really want to stress, this is not an issue of access. This is an issue of whether you're going to be able to afford to have insurance and whether you're going to be afford to have the health care, even if you do have insurance, because you have to pay more and more out of pocket. And he also mentioned continuous coverage. Well, that's fine, but lots of people don't have continuous coverage. They lose their insurance. They go off their insurance. They can't pay their insurance from time to time. And in this bill, there's a 30% penalty if you don't have continuous coverage. And that affects people with pre-existing conditions and some of the other people that have been mentioned by my chairman. And then he also mentioned, he referenced Medicaid's limited resources. I have to be honest with you. I'm tired of hearing about the fact that Medicaid is unsustainable from a financial point of view. You are cutting out something like $800 billion out of the Medicaid program. Well, of course, if you cut out $800 billion out of the Medicaid program, which is almost the whole cost of the Affordable Care Act, it was estimated about $1 trillion, then you're not going to be able to provide Medicaid coverage for the working poor. And we are talking about, with enhanced Medicaid, for the most part, we're talking about the working poor, people that are working, but they don't get health insurance on their job, and they can't afford to buy it in the individual marketplace. So what happens? Again, no disrespect, but Chairman Walden said the states are going to be great innovators. They're going to have all kinds of options, all kinds of flexibility. You don't have any options if you don't have any money. And I'm telling you, in my state of New Jersey, and I know most of the states because we met with the governors, including Republican governors, they are very, very much afraid that they're not going to have the money to make up the difference. You take the money away, and what's going to happen? You don't have essential benefits package anymore or essential benefits guarantees under expanded Medicaid under this bill. So they're going to have to cut back. They're not going to be innovators. They're going to cut back. They're going to cut back on mental health care. They're going to cut back on a treatment for opiates. They're going to cut back on the money that goes to nursing homes. Nursing homes are pretty good facilities right now. I remember in the 70s when they were so bad they were burning down in my district. That's what you're going to get. You're going to get a Medicaid program where the states are going to have to kick people off Medicaid, or they're going to have to provide so much less in benefits. Now, again, I just want to, I know that Chairman Sessions and Chairman Black, a lot of what I call ideological arguments. You know, I hear things like freedom, choice, competition. I don't really want this to be an ideological debate. This is not a single-payer system. You mentioned TennCare. I don't know what, I used to hear from Marsha Block a lot about TennCare, as Dr. Burgess knows. But the fact of the matter is, this is not a single-payer system. This was a private sector, if you will, response, private response, if you will, to a real problem. And we're talking about real people here. So, I mean, you could talk about all this ideology, but the fact of the matter is real people are going to lose their insurance. Now, you know, I wanted to just mention the CBO. I know there's a lot of talk about CBO. The fact of the matter is the CBO basically said that more people fewer people are going to have insurance under your bill than had insurance before the ACA even went into effect. Something like 24 million people are going to lose their insurance. Premiums are going to go up. You have taken away the limitations that we had on the ACA in terms of deductibles and copays. So deductibles are going to go up. Copays are going to go up. This is what the CBO is talking about. And I haven't heard any, third-party, nonpartisan group to dispute the CBO. No one. That's why the CBO score is important, not only for the original bill, but also with the manager's amendment, because no one's disputing, really, essentially, nobody other than, Republican or, conservative think tanks maybe, nobody is really disputing what the CBO said in a nonpartisan way. And the fact of the matter is, people are going to be harmed. So again, I don't really want to talk about the ideology. I want to talk about what this actually means. And so, I'm just going to conclude by saying this. I really think it's your obligation to show how this is going to be better than what we have now under the Affordable Care Act. And I think that burden on your part, you've totally failed. And if anything, the manager's amendment makes it even worse because it's even more cuts and less money that's going to go to states. And I think ultimately we might find, if we do get a CBO score, we might find out that even more people are going to lose their insurance. And so just think about this in terms of what it means for real people. I think there's no question that what it means for real people is that this is a really bad bill. And I'll just end by saying, look, we're willing to work with you. If you think you have some improvements that can be made, fine. But what you've put forth is not an improvement. What you've put forth is actually going to harm people, real Americans. Thank you. I yield back.
Mr. Blown, thank you very much. Appreciate your insight. The gentleman from Massachusetts, my dear friend, Mr. Neal.
Thank you, Mr. Chairman.
Yes, sir.
Thank you, Mr. McGovern, as well. Mr. Chairman, point of clarification. Are you suggesting that if you do not have a CBO score in the next hours, that you are not going to bring this measure to the floor tomorrow?
Let me see if I can ask you to suspend just for 1 minute. The gentleman, either Chairman Brady or Chairman Walden or Chairman Black, do you choose to address that issue as you are closer? I was preparing for this meeting yesterday, not getting a CBO update, and I do recognize the gentleman, Mr. McGovern, Mr. Polis, and the judge have been after me for that. Do either of you have a new update, gentlemen, from Texas, Chairman Brady?
So we anticipate CBO to give us a new score before the bill moves to the floor, with ample time for members to be able to review it.
Okay, I have a question. Did the gentleman say the score will be available before it goes to the floor?
Before we vote on this bill, we anticipate having this score from CBO. I can't give the exact timetable for it, but I know they've been working on the manager's amendment. We do anticipate that today.
Mr. Chairman, could I just have a follow-up?
I think it's fair for us to attempt to answer the gentleman's question.
Could I reclaim my time for a moment, Mr. Chairman?
If the gentleman will suspend just for 1 minute. I am now going to yield back to the gentleman, and if the gentleman would like to engage the gentleman, he may.
I will, but, so in reference to the point that Mr. Brady and Mr. Waldron have just suggested, in the absence of a CBO score, do you intend to proceed tomorrow?
Okay, let me see if I can.
And then I will yield to Mr. McGovern.
Let me see if I can allow you to ask questions, and if Chairman Brady then wants to come into this. I am proceeding on this and was offering my viewpoint that we felt like it would be available this evening. That this evening viewpoint would mean that we would have it before we would move to the floor on the rule.
I would like to yield a couple of minutes to Mr. McGovern.
I mean, this
Well,
whole...
he does not need time, he just needs to answer the question.
Yeah. I mean, this whole process is screwed up. I mean, the idea that we might conceivably debate this entire bill tomorrow and get the CBO score, prior to our 15-minute vote on final passage is crazy. I mean, the reason why I want a CBO score is so we have the facts in front of us. We shouldn't be proceeding in this committee without a CBO score. So it sounds like the answer that we're being given from the chairman of the Ways and Means Committee is that as long as you have it before you cast your vote, that's good enough. Well, I don't think it is good enough. I think people ought to have it well in advance so they know, we all know what we're talking about. Maybe it'll come tonight, but if it doesn't, it sounds like you're going to proceed with consideration of this bill, and we're going to be debating a bill without a CBO score.
Gentleman yield?
Yeah, I'll yield to the
As we did 7 years ago when not even one was requested.
I'm
by the
just saying, Mr. Chairman, I think this is a screwed-up process, and And I think the record is clear that we think we ought to wait until we get a CBO score before, especially given the fact that we know from the initial CBO score that 24 million people are going to lose their health insurance. I yield back.
Thank you, Mr. Chairman.
Yes, sir.
And, Mr. Chairman, I would like to begin also by submitting a letter from Governor Baker from Massachusetts.
Without objection, I'll be into the record.
To the record, as he raises questions about what you intend to do today. And I want
Yes,
to
sir.
also acknowledge and begin by thanking former Governor Romney in Massachusetts for having worked with the Democratic legislature and having worked with the Chamber of Commerce and the AFL-CIO and the American Nurses Association and the American Medical Association as we devised a plan that in many ways became the model for the ACA. And I might point out that it polls well into the 70s today in terms of customer satisfaction. So, Mr. Chairman, the bill itself in front of us this morning is a danger to the American people. And none of the proposed amendments would improve the legislation to any appreciable degree. In fact, most of the amendments that have been filed make the bill more draconian and more harmful to America's health. In particular, the manager's amendment that accelerates what really is a tax giveaway to people at the very top. The combined tax cuts now total nearly $900 billion, while more than $1 trillion is taken from the Medicaid and Medicare trust fund. Like millions of Americans across the nation, my constituents recognize the danger posed by this legislation. Millions of middle-class Americans will be worse off, while many millionaires will be better off and reap the actual tax benefit. Governor Baker wrote the following, quote, "Overall, our analysis indicates that the AHCA would increasingly strain the fiscal resources necessary to support the Commonwealth's continued commitment to universal health care coverage. The bill would not lower cost," end of quote. The bill would not lower costs for consumers. In fact, CBO confirmed that Americans will face higher costs and less value. Let me be clear. The changes being contemplated by Republicans make it even more difficult for Americans to get the needed care at an affordable price. I have heard Republicans tout the CBO number that premiums would be 10% lower in later years under that plan. We've really never had an argument in the 28 years I've been in Congress about lowering health care costs. It's how to restrain the growth of health care costs that has really been the argument. And I think that that needs acknowledgement as well. But what they don't say is that these alleged lower premiums would apply only if you can afford coverage with a paltry tax credit. And there's no guarantee that coverage would provide the benefits that are needed. In fact, if you really look at what CBO says, they make it clear that Americans would get fewer benefits at a higher cost overall. Premiums that are 10% less are irrelevant if you can't afford the price of the policy to begin with. And CBO is clear that total out-of-pocket costs would indeed go up. The Republican plan reminds me today of a used car salesman giving a 10% discount on the cost of a car, but only if you want tires, an engine, and a windshield, you're going to have to pay more. That's hardly a recipe that is acceptable to my constituents. The bill doesn't cover everyone, as President Trump promised. CBO estimates that 24 million Americans would have less coverage under this Republican scheme. The Republican bill is really a tax cut for special interests masquerading as a health care bill. This bill would cut $880 billion from Medicaid, the program that helps pay the costs for more than 60% of all nursing home residents nationwide. I would suggest to members of the committee here that we all have the following understanding, that Medicaid in many ways has become America's long-term care initiative. It also is a massive tax cut to the people at the very top. President Trump's cabinet, with a combined worth of in excess of $13 billion, would be amongst those who would benefit handsomely. The Republican plan really harms my state of Massachusetts by cutting Medicaid funding that is used to pay for opiate addiction treatment, and my goodness, I hope we can all agree upon that long-term care and children with special needs would also be cut back. And by cutting the tax credit that helps families afford coverage in the Mass Connector, and by letting health insurance companies reduce the value of the coverage they offer, we all acknowledge the challenge that that would present. And we know that more uninsured means more burden on our local hospitals. We will see job losses and hospital closures, something our communities can't afford. A new study this week finds that nearly 3 million jobs could disappear under this approach. But for those who dismiss any analytic study that disagrees with your policy as fake news, look at what the experts say about these jobs. According to the American Hospital Association, there are 14,800 hospital jobs in my district, and my community would be hard hit if one of our local hospitals closed, both because care would suffer and because constituents would lose good-paying jobs. Yet, the direction that the Republicans take on this bill would be severe in the consequence for the people of Western Massachusetts. So we've got a bill that breaks promises, we've got a bill that raises costs, we've got a bill that reduces coverage, and we've got a massive tax cut for the people at the very top. Put simply, this Republican bill forces millions to pay more for less care, and while raising and not lowering the number of uninsured Americans to 52 million. That's not enough damage to inflict on America. The measure also would cut the life of Medicare by 3 years and $175 billion when millions of baby boomers will rely heavily upon this critical program. When I hear Republicans, as they have frequently done, address the issue of Medicare, they continually talk about the Medicare Trust Fund and the shortness of the Medicare Trust Fund's life expectancy, and then they turn around and cut 3 years from what the trust fund accountants say is realistic. That's the equivalent of saying, let me set the fire and then call the fire department. As I noted earlier, this provision, coupled with the Medicaid cuts, robs more than $1 trillion from health care programs that really 120 million members of the American family depend upon. Let me take a brief moment to contrast this Republican bill and what they're proposing with the ACA and what it did. The ACA added 11 years of life to the Medicare Trust Fund. It did so by improving the efficiency and the quality of payments to Medicare providers, looking at evidence where the program could indeed work better. That's an important suggestion. There were experiments that came along with the ACA. The ACA did not drain the trust fund, it strengthened it. The legislation before us robs the trust fund in order to give a tax cut to those at the very top. Who does it hurt? It hurts all of our constituents. Let me conclude by saying that this legislation is the Republicans' first attempt at tax reform. As such, it fails the test set out by Secretary Mnuchin for tax reform that, quote, he said, there will be no absolute tax cut for the upper class. This bill provides a tax cut for the wealthy and the healthcare industry of almost $600 billion while hurting middle-class citizens through their cuts to health care. Americans will be paying more and getting less. I urge my colleagues in the Rules Committee not to move forward with this bill in terms of bringing it to the House floor. I will submit this to you, Mr. Chairman, with great regard for the members of this committee and those that are testifying today. When President Trump said, "Who knew how complex health care could be?" that ought to be the starting point in the conversation, because for those of us who have been on the Ways and Means Committee for a long period of time, we knew just how complex health care can be in America. And I guarantee you that the one experience we've all had with the development of health care proposals, it's like squeezing toothpaste with the cap on. Sometimes you simply don't know what some of the consequence will be. To go down this path in this manner is a huge mistake. There was a chance here for all of us, and I'd be happy to debate how the ACA came to formation, how the ACA was finally passed, and the opportunities for all to play based upon some statistical data I brought along as to the number of committee hearings, town hall meetings, amendments, and the number of Republican amendments that were accepted in the ACA, oftentimes left out of the argument. A lot of the problems emanated from the Senate as they prolonged the discussion going forward, trying to secure more bipartisan help for it. And when that didn't work, one party decided to go forward. But we have an example here today where both sides could, in fact, mend this legislation and go forward. Always remember that there were a lot of Republicans that voted for Social Security, and there were a lot of Republicans that voted for Medicare and Medicaid. And I yield back my time.
I appreciate the gentleman very much, not only for his time today, but his insistence that we listen not only to wise opportunities, but that you've come to the committee to give us your very best, and I appreciate that very much. Mr. Yarmouth, a couple weeks ago, we had John Yarmouth Week up here. It seemed like you were here every other day. We're delighted that you're back. I noticed that you wore your tie in deference to the gentlewoman from Tennessee, and she noticed that. I did too. The gentleman's recognized.
Thank you very much, Mr. Chairman. Ranking Member McGovern, it's an honor for me to be here today. Members of the committee, it's an honor to be here with my colleagues, and I certainly join the chairman and others in wishing the speedy return of my fellow Kentucky native, Ms. Slaughter. When the nonpartisan Congressional Budget Office released its report last week showing that 24 million hardworking Americans will lose their health coverage by 2026 if we pass the bill, that premiums would rise 15 to 20% with higher deductibles and out-of-pocket costs, and that middle-aged Americans would be priced out of the insurance market by an age tax, I thought for sure this bill was dead on arrival, that there was no way Republicans would walk this plank. I would not want to, nor would I know how to, justify giving $900 billion in tax cuts to corporations and the wealthy, paid for by threatening the health and well-being of millions and millions of American families. Mr. Chairman, when I was here in January, you invited me to meet with you about your health care replacement bill, the world's greatest health care act, as you named it. And while I wouldn't necessarily agree with the characterization in the title, and don't agree with many of the ways in which you propose to change the Affordable Care Act, it was and is a serious and thoughtful proposal. And I do think it's worth pointing out a major difference between your bill and the legislation this committee is about to send to the floor. Your bill does not provide billions of dollars in tax cuts to corporations and the wealthy. You keep that funding in our healthcare system and reorganize it. You recognized, as we Democrats do, and as CBO did, that it's impossible to cover as many people and provide better quality of care while making drastic cuts to our nation's healthcare programs. It's unfortunate the same logic is not reflected in the bill we are debating right now. But let's be honest, this so-called replacement legislation is not a healthcare bill. It is an ideology bill, a fantasy about freedom and choice existing in a market that doesn't exist. As I said during our markup in the Budget Committee, Speaker Ryan loves to talk about giving people the freedom and choice to decide whether to have health insurance or not, and giving insurance companies the freedom and choice to cherry-pick young, healthy enrollees and sell them cheap, stripped-down health plans. That would work if young people also had the freedom to choose whether to get cancer or not to get in a serious accident or not, which they obviously don't. But that doesn't stop Speaker Ryan from pretending that this bill will create some magical health care free market that exists nowhere else in the world. A fantasy land where young people don't get sick, and apparently they don't grow old either, so they don't have to worry about being priced out of the market. That's just sheer nonsense. But what this bill actually does is striking, particularly given what was promised, and considering that the CBO score of coverage losses from the pending manager's amendment has not yet been factored in. Under this legislation, the number of people without insurance in the United States will nearly double. 14 million Americans will lose coverage next year. That number increases, as I said, to 24 million people by 2026. 21 million Americans will lose coverage in the next 3 years alone. That means all of the coverage gains from the Affordable Care Act will be wiped out in just 3 years. The CBO also estimates premiums in the individual market will jump by 15 to 20% in 2018 and 2019. Yes, by the end of the decade, CBO says premiums will be 10% less than current law, but a main reason for that drop is largely because older people will be priced out of the market. For pretty much everyone else in the individual market, deductibles and other costs will be higher, and for lower-income individuals, out-of-pocket costs will be much higher. Insurance companies will again be able to sell plans that offer much less financial protection, and we will return to the days where millions of people in this country live in fear that they are always one serious illness or car accident away from bankruptcy. Mr. Chairman, President Trump and members of congressional leadership repeatedly said this replacement bill would preserve existing coverage, that everybody would have insurance, and it would be less expensive and much better. None of that is in this bill. In fact, the exact opposite of every one of those promises is what's in this bill. Those were promises made to every family in our congressional districts, and this bill fails them at every turn. As my colleagues have said, we can improve the Affordable Care Act, and we should, but this is not the answer. I urge my colleagues to oppose this legislation, and I yield back my time.
Mr. Chairman, thank you very much. Okay, we've now been through our opening panel. It's an opening panel that offered a vision and an alternate vision. It's a panel that offered a fight that is going on all across America. This last weekend, I had an opportunity to engage people in Dallas and Richardson, Texas, not only in the health care bill, but also other things that are facing our country. And I recognize that an insistence by people to stay where they are or want to move where they go has put a collision point. This morning, Dr. Mark Mazow, who is an ophthalmologist from Dallas, Texas, engaged me. Last night, Dr. John T. Gill, a orthopedic surgeon from Dallas, I know both these gentlemen very well, they engaged me and said, and people are delaying and not going to get health care that they need because premiums are not only high, but deductibles are the real reason why people are delaying themselves the opportunity to go get things done. Mr. Chairman, I'll look at all three of the chairmen that are here. That's a problem. What is this bill going to do that will help deductibles? We keep talking about premiums, we talk about cost, but part of that cost is deductible. And you evidently identified, and I know Dr. Mazow talked directly with you about doctors are concerned.
Yeah, I've heard from patients and people who don't get the subsidies provided under the Obamacare plan, which just go to the silver plan and the CSRs, and they're saying the same thing. These people are out of options. Their deductibles have gone up. They're working folk who just, they're the middle class, and they're getting priced out of this market. And they're coming to me and saying, what are you going to do for us? What are you going to do for us? We pay our taxes, we're working, we're forced into this market, and it's collapsing around us. Our deductibles no longer are $500 or $1,000, they're $10,000 or whatever the number is, $7,000. And so they're saying, help. And so what we try to do here is a couple of things. One is restore to the states more power on the decision-making when it comes to health insurance plans. Because we actually put faith in local and state leaders who are there on the ground. They know better than somebody sitting here in Washington on what may work best. My district in Eastern Oregon is much different than the metropolitan area. And I would have faith in my state of coming up with a plan that would work for a more rural, lower income group that I represent than maybe an upper income group in Portland. They'll have some flexibility here, so we do that. Second, the Patient Stability and State Stability Fund. It's $100 billion to the states to come in and help on these issues, to help buy down premiums, help buy down deductibles if necessary. If they don't need to do that because they fixed their market and it works on its own, they can put that toward additional mental health services or opioid and mental treatment services. We give them flexibility and funding to design a healthcare system that works for them. So, I mean, there are multiple things we're doing here, but if we don't fix these markets, they are collapsing. My colleague from Tennessee, your old state, right, has one option in the exchange. We've got a couple in Oregon.
So competition would be one answer.
Well, that's what we're trying to get to. And let's understand about, with all due respect to CBO, at this point in the process, CBO said there'd be 21 million people on the individual market end of the Obamacare exchange. That's what they forecast for 2016. 21 million people would have insurance. Do you know what that number is today?
12.2.
It's 10.4.
Oh, I saw last week that they said 2017 was
10.4 right now.
10.4, Chairman, thank you.
So,
Mr. Chairman?
Excuse me just a second, please. I will allow the gentleman a chance.
So the point is, they're off, and there's a reason they're off. I mean, people said, I'll pay the penalty of the IRS or get a waiver rather than sign up. That's about 2/3 of them, and 45% of those who decided to pay the IRS penalty, because remember, the coercive agent here is the IRS. The tax man says, buy this government-mandated product or pay a penalty. 45% of those under the age of 35 said, I'll pay the penalty or I'll get a hardship exemption and opt out. So We're trying to create a program that works. And in terms of creating a plan that works, I'm 60 years old. My cost is 4.8 times higher on average than my son who's 26, right? And what Obamacare did was artificially compress that band to a 3-to-1 ratio rather than a 4.8 or 5-to-1 ratio. So what we do in this bill, we get a lot of criticism for it, and I think it's unfair. We go back to what the market actually is, 5-to-1. Now, states can go lower. They could go to a 3-to-1, a 2-to-1 if they wanted. They could go to 5-to-1 or 6-to-1 or 7-to-1. We say you design it because some states have younger populations, some older. We're just giving them the flexibility. So if the plans are going to be too expensive, they can adjust that. We give them the ability to make some fine-tuning that works in their state. So it really becomes less Washington telling Massachusetts what works and telling Oregon what works. By the way, it has to be the same thing.
Thank you. I have a follow-up question, gentleman from New Jersey.
I mean, briefly, Mr. Chairman, I couldn't disagree more with what my committee chairman says on this issue. Bottom line is that when we put the ACA in place, it was because what was happening in the states and the marketplaces was failing. And that's why we got rid of all those discriminatory practices on pre-existing conditions and lifetime caps and all that kind of thing. So for me to assume that now if you throw this back to the states that somehow they're going to do things better, well, first of all, you don't even agree with that because you've kept 60% of the Affordable Care Act and you've kept a lot of those discriminatory practices, anti-discriminatory laws that put restrictions on the states because obviously you don't believe that if you repealed those things like a pre-existing condition prohibition, that the states would do the right thing. So why should we believe that the states are going to do the right thing? And the second thing is, with regard to the CBO, one of the things the CBO says is not only people are going to lose their insurance, $24 million, but a lot of people's deductibles are going to go up because what we did with the ACA is we put limits in those various plans on how high those deductibles could be. And I know people are complaining about deductibles, sure, because maybe they think they're too high, but the bottom line is that in your bill, you let the deductibles go through the roof, and the same with the copays. So again, if you're going to let states say, okay, you can raise deductibles or you can increase the rating system, so for older people, instead of paying 3-to-1, they go to 5-to-1 or 6-to-1. This whole idea that somehow by letting loose the states on the age rating, on the deductibles, on all these other things that we limited, I think is a huge mistake. And that's why the CBO says that, even if you have insurance, what kind of insurance are you going to have under this Republican plan? Not good options.
Thank you. Mr. Chairman, you're going to allow the states of flexibility on all these matters, 26 years old?
No, they're protected.
And
it's kind of ironic to hear my dear friend from New Jersey describe that these were only Democrat ideas and therefore, I mean,
yes, but the
dealt with some of this stuff
flexibility,
in
I
the
heard
state
you describe the
legislature.
flexibility in the
Right.
rating.
Right. So
Is there other flexibility as it relates to the pertinent parts that were in the ACA that he spoke about?
Yeah, because we get rid of the metal tiers that mandated certain expenditures for certain things at certain rates.
Okay.
So when you have a government that says, here's what you have to buy, and then an IRS that says, if you don't, I penalize you,
agree with that.
That doesn't necessarily create a market. So let's talk about one other thing he doesn't mention, and that is last year there were 225 counties in America where there was one option on the exchange. This year that's 1,022. By the way, Mr. Chairman, that's 1 out of every 3 counties where people that have no option but to go on the exchange have no option but one choice. And we believe that was before Humana pulled out of the market. And we've heard from some insurers, some pretty big ones, who have told us this year isn't looking very good either. And they may consider pulling out, or they may have to have some pretty substantial rate increases. So the notion that everything's perfect and fine, I think, is not accurate. And I think we can do a lot better, and I think what Mr. Brady did in the Ways and Means Committee to expand health savings accounts.
That was where I was
Also,
going. I didn't want to prejudge the question, but the HSA
this is a
provisions-
really important part of this. And remember, the Democrats wanted to clamp down on what you could do with your HSA. You remember hearing from the disability community on that point of what you could spend the money for, the over-the-counter piece, the taxation pieces. All of that's in there. I mean, I talked to one insurer in my state the other day who said the health insurance tax itself, remember they tax health insurance. Does that drive down cost or drive up cost? What do you think happens? Was a huge part of why they had a debt last year. And so they try and pass that stuff on. But who do you think they pass it on to? Do you think that lowers rates? We generally tax things we want less of, right? Tobacco. So we tax tobacco, you want less of it, with all due respect to Mr. Cole and cigars and all that. But it's what happens, right? And so why the Democrats wanted to tax health insurance. They wanted to, and if you have too good of a health insurance, they wanted the government to say what that health insurance should be. And if it was too nice, too good of a plan, like a lot of the people in the building trades have, they wanted a 40% tax on that. They negotiated for those rights.
Sure, Mr. Brady, this HSA issue, as I recall, it's really a great option for a family to be able to control not only their spending, but the way at which they receive their health care, because they get it on a tax basis. What have you done in this bill that's directly related to the questions about the cost?
Well, you know, my local doctors are concerned too. They know, and they tell me Obamacare is a sinking ship, and it's taking a lot of good Americans down with it. They had patients who were kicked off their plans. They can't see them anymore. The plans in Obamacare that they have are too expensive, and they can never seem to get through all their out-of-pocket costs to get to the surgeries and procedures and treatments they really want to get as well. In the Houston region, we have no PPOs left. One very skinny one, it's gone. So their patients can't even see them anymore or go to the major hospitals.
What are you
in
going
the
to
medical
do
center.
to create a
Yeah.
better vision for people?
So
that
this
describe that
approach is to
scenario?
reject the direction Washington, one size fits all, expensive healthcare, expensive subsidies you can't use, for affordable healthcare tailored to your needs. And part of that, giving patients choice, is the ability to double the size of their health savings accounts, make sure they can use it for what they need, like over-the-counter medications, for example, to be able to cover those out-of-pocket costs that are so expensive so they can see that local doctor. And we give them more control with the tax credit to buy plans that are right for them, tailored for their community. For example, there's just a big difference between Manhattan, Kansas, and Manhattan, New York. Our healthcare plans should reflect that. Unlike Obamacare, our approach is to allow states to provide a wide variety of products, choices for people that work in their communities and their regions versus Washington. That's why many of my local doctors are telling me, please repeal this monstrosity, restore the doctor-patient relationship, let my patients come see me again.
And grow back that market access. Mr. Yarma?
Make several points. First of all, I understand there's individual physicians who don't support the Affordable Care Act, but also I want to point out the American Medical Association, the American Nursing Association, the American Hospital Association, AARP, and virtually every disease-related organization has come out opposed to the American Health Care Act. So they don't see this as a viable option to the Affordable Care Act. Secondly, to point out that health savings accounts are wonderful ideas for people with money. If you don't have several $1,000s to set aside, then HSAs mean nothing to you, and the vast majority of the people we're trying to help, either through the American Health Care Act or through the Affordable Care Act, don't have several $1,000s to set aside. And finally, I want to point out that what we're talking about here almost entirely relates to the individual insurance market. That market is basically affects about 5% of the American people. For the vast majority of the American public, the healthcare system is working pretty well, whether it's Medicare, Medicaid, or employer-based insurance. We're talking about a very small sliver of the American public. They are important people, but we should not try to upend an entire healthcare system that is working well, relatively well, for 95% of the people to solve a problem that relates to so few.
Thank you very much. Mr. Neal?
Thank you, Mr. Chairman. I think there's one thing we can all agree on as members of Congress today. Not one of us has ever met a Medicaid recipient who had an HSA.
But I have met some that want it. Okay.
Well, if I could, Mr.
yes, sir.
Chairman, in a study there are 20 million Americans who use health savings accounts today. In a study, nearly half lived in neighborhoods with median incomes between 25,000 and 50,000 people. These are middle-class Americans who use them for these high out-of-pocket costs.
Can I weigh in too? Because the fact of the matter is, in Indiana, they use health savings account as part of their Healthy Indiana plan with their Medicaid patients. So they actually have them. They make them work. And by the way, we should be doing more for the middle class too, who needs help in this area, who's been left out.
That's
So we're
what the
trying
tax-
to tackle
that's what that tax
multiple.
credit's there for.
That's right. There are multiple folks who need help out there beyond Medicaid. So we're trying to provide flexibility and new options for people who are lower income. We're trying to help those who are in between. This isn't just one size fits all, which I know some of my colleagues think is all that comes out of Washington. We're trying to help multiple people in multiple life situations be able to afford and get access to health care.
Well, I think what you really did without saying it, because I've studied this issue, by the way, I will go back to anybody that said it's hard writing bills. It took me a year and a half, almost two, to do this. In about month 16, I looked at my staff and they looked at me and we said, we know why not many people write health care bills. There is a reason why it took us a long time. But the moral issue that's involved here was overwhelming to me. As you know, Mr. Chairman, I have a Down syndrome son who participates into a program that is necessary for him as a result of my age to make sure he's on that program for the rest of his life as a Down syndrome young man. But there are many able-bodied adults that are on there who have the need still for health care, and when they're on Medicaid, they are limited in the amount of work they can do. And so I viewed this as a moral issue to allow them the chance to jump free to a tax credit system and evade that other, what I consider to be a system that would not give them the flexibility that they need. We're going to keep going. This is all-day fun, and I know we're about to get to Mr. McGovern, but we're first going to go to the gentleman, the Vice Chairman of the committee, my dear friend, Chairman Cole. Chairman?
Thank you, Mr. Chairman. I appreciate that. And I will have fewer questions because I had the good fortune of being in Chairman Black's committee with my good friend from Kentucky as well last week. So we had a pretty thorough education about the bill. But there are a number of things I'd like to ask for the record. As my good friend from Oregon knows, I spend a lot of time on Native American issues. And a number of years ago, we had a very good piece of legislation. Mr. Pallone was a big part of that, the Indian Health Care Improvement Act, which was bipartisan and was moving along through Congress, but then was added to the Affordable Care Act. So as a result of that, I get a lot of questions, and I just want to make this clear for the record. There's nothing in this legislation that repeals or undoes any part of the Indian Health Care Improvement Act. Is that the case?
I appreciate the question, Mr. Vice Chair. I think it's an important one because I know that issue has been raised in other venues. The clear answer is no. There's nothing in here that affects the authorization of the Indian Health Services Act.
I appreciate that, and I just add, for some of my friends who only want to do a repeal option without a replacement option, if we were to do that, that's exactly what would happen. We would repeal a number of things that all of us agree on. Actually, there's a lot of contention here, obviously, a lot of different points of view. But there are things in the Affordable Care Act, and we've mentioned Republican ideas about raising the age to, or allowing people to stay on until they were 26 and their parents' insurance. This is a very significant piece of this act. And again, I thank my friend from New Jersey for the role he played in that. But if we just did a simple repeal, those items would go. So I want to commend you guys for, I think, doing the hard work of actually looking through and making tough value decisions. I know there's still a considerable amount of disagreement here, and that's fair enough, but there is a lot of consensus here. So where in those areas where there is consensus, I want to commend both of you and obviously Chairman Black as well, who I think offered some really terrific suggestions for improvement of the original bill and through her committee, but for keeping those things in. Very important.
Chairman,
yes, sir. I'm certainly yield to my friend from
I just, I appreciate your mentioning that because you're absolutely correct. And Mr. Chairman Walden's response is absolutely correct. And again, appreciate the fact that you guys have kept some significant things that we had in the Affordable Care Act, including the Indian Health Care Improvement Act. But I would point out, as you know, that when I meet with the tribes or go to the various conferences that were held in the last few months, they are very concerned about the impact of this Republican repeal, both on those American Indians in the individual marketplace who will lose their subsidy and don't believe that the tax credit will make up for it. And at the same time, many American Indians who have been able to take advantage of Medicaid expansion in those states that have, who are concerned that by eliminating or significantly cutting back on the expansion and the per cap or block grant on Medicaid, that they're going to either lose their insurance or have significantly less benefits. So the fact of the matter is that as important as the Indian Healthcare Improvement Act is, it's also important for tribes that they not see cutbacks in Medicaid and that they not see significantly less subsidies or tax credits for those on the individual marketplace. So that, you know, it's not a panacea that we've kept the Indian Healthcare Improvement Act in place, although I do appreciate that.
No, but we did. Well, my friend from Oregon.
Well, I was just going to say, Mr. Vice Chairman, I also want to make sure people understand that our Committee on Energy and Commerce is also, I've asked Mark Wayne Mullen to head up a task force to look at the actual delivery of health care in Indian country, because we've heard reports about low quality, and we want to get after that, because all Americans deserve high-quality health care, and the reports that have come in from some reservations would indicate they're not getting that.
Oh, they're
There's a
certainly not. You know, my friend's absolutely correct about that. We had 3 hospitals in Indian country that were lost emergency room privileges and surgical things last year. The Indian Health Service, I actually worked with the previous administration try and get those up and running again, and I've already had a couple of conversations with our good friend Dr. Pryor, the new secretary, about these issues. A lot of them go well beyond, honestly, the insurance issue that we're dealing here. Everything from remote locations to the difficulty of recruiting trained personnel. But it's an area that's going to need a lot of work. The tax credit, though, is actually a potential vehicle to help a lot of people that aren't getting help. And on terms of Medicaid expansion, my friend makes a good point, but for Indians in 19 states, which include my own, that doesn't matter very much because we're not a Medicaid expansion state, and those decisions were made, largely out of fear that conditions would change and the states would have to be paying a lot more than they do. So we can debate that a variety of ways, but at least on the area where we agree, your committees did keep that in, and I want to thank publicly both of you for doing that. It's a big.
I would also mention, Mr. Vice Chair, that in our legislation, we turn off the DSH cuts, the disproportionate share cuts to hospitals in non-expansion states 2 years ahead of when remember under Obamacare, the hospitals got whacked. And we turn off those cuts to those hospitals in non-expansion states. We have safety net funding as well for those states, and we have money in the patient and state stability fund for those states.
As usual, my friend anticipates my questions, and I appreciate that because I can make a pretty good argument in my state where, frankly, we are down to a single provider like my friend from Tennessee is, and where our rates are going up 69% for those people on the exchange. We are actually much better off in Oklahoma with the additions that you've added and the tax credit provisions than we are under the current system. Now, I'll leave it to everybody here to determine that for themselves in their own respective states and jurisdictions. But it's a pretty powerful argument when I talk to people about where we are and what this provides in addition to what's available out there now. Again, for my state, my area, this is an improvement. And let me ask you a theoretical question. Obviously, we're going to be considering amendments here, but this process is a long, winding road, as my friends on the other side would agree. They have walked down it themselves before. Do you anticipate there'll be changes made in this legislation as we go forward?
Well,
I'm not asking you to predict what they are, but you guys
Yeah.
have been around the block a few times.
Look, this is a legislative process, and when you're covering a key issue so important to Americans and each of us, you're always looking for improvements at every step of the way. We've worked very carefully to incorporate improvements provided by the broad range of our Republicans, from rural to cities, to Indian communities, to metropolitan areas, in ways that we can help cover more people with affordable health care and give them choices. I assume the Senate will continue that improvement process as we hand this ball to them as well. They have creative ideas, they've certainly suggested many to us. And so, I'm hopeful that we continue that process till the bill gets to the president's desk.
I would concur. I know we gave members of both parties the opportunity to offer up amendments in committee. I think, I'm told by the historians, we set a record for the length of our markup, 27 hours and 27 minutes. Unfortunately, we spent the first almost 12 hours, maybe 10 on the First Amendment from my friends across the aisle who had an amendment simply to rename the bill. It wasn't really a substantive amendment that addressed any issue that's a problem that our consumers and our voters are talking about. It simply would rename the bill, and we debated that for 10 hours or something before we voted, which didn't seem to be very thoughtful approach to the importance of this matter, but that was where they chose to go. But we kept the doors open until they were done with amendments, and my side was done with the amendments. But I think going forward, I wouldn't want to prejudge what you all do here in the Rules Committee involving amendments, nor what our colleagues in the Senate may offer as well. I think we should admit that there are problems out there in accessing affordable care, in options for insurance for our consumers, and we ought to go shoulder to shoulder and figure out how to solve them.
Well, I think my friend Chairman Black will have some excellent suggestions for this committee that came out of her committee, and I anticipate they're going to be favorably considered. So I'll venture a little prediction there. But I think that's an important point to realize. This isn't a once and forever bill or vote or anything of the kind. We're in a legislative process, and what we do here today isn't going to be the final word. What we do tomorrow, assuming this bill comes up, and we have the CBO scored, et cetera, won't be the final thing. I mean, it will continue to change and improve. And I must say, and I say this with great respect to my friend from Tennessee, I think coming out of her committee were terrific improvements in this bill. And I'm very proud of, I know even people that will vote against the bill, my good friend from Kentucky, who made that very clear, but did support one of the amendments in there because he thought it made it better, which I thought was a generous and thoughtful way to proceed. So, gentlelady has any comments, I'd love to hear them.
Oh, Mr. Vice Chair, I appreciate that, and the ranking member and 6 of his colleagues supported that suggestion that we have passed on, and I keep telling my colleagues that they need to have their voice heard, not just in the media, but also to let the leadership know what their thoughts are. We all need to stay in the fight. And as I've said before, legislation, and we all know that that analogy that's made is kind of like sausage. It's not pretty watching it being made, but tastes pretty good at the end when you get it right. So I think that is something we have to encourage all members to continue to bring their suggestions forward. Thank you.
I hope you don't have all those suggestions today, but I think we're going to get quite a few of them. Let me ask this. There's been a great deal of discussion amongst the 6 of you about people losing coverage. Does anybody actually lose coverage? First in 17, 18, or 19, and frankly, does anybody that's on coverage now ever kicked off of coverage if they want to stay there? Because I think there's a lot of confusion when people hear 24 million people are going to lose coverage, as if they're going to be summarily denied coverage.
Well, thank you for sort of busting that myth of 24 million people being kicked off. That's not what CBO showed. It showed the bulk of Americans, when not forced to buy health care they don't want and can't afford, they choose the option of not having that health care that they can't use and can't afford. For example, next year, with no changes in Medicaid and no changes in the exchanges at all, other than Americans are no longer forced to do it, nearly 11 million Americans say thanks, but no thanks, that's not what I wanted anyway. And that continues through the bulk of the 10 years of this. Americans voluntarily saying, thank goodness I'm no longer forced into a plan I don't want, can't use, and can't afford. For other Americans, the reason we're taking such a deliberate approach over the next 3 years to make sure that states can approve a wide range of products and insurance companies can now, with the free market, provide different choices for them. In that immediately usable credit, every American will have plenty of time to be able to choose a plan that's right for them. And I will finish with this. In America today, this doesn't get much media coverage, but for every one person on the Obamacare exchange, 2 Americans have said no thanks. Most of them have actually paid to say no thanks. I mean, think about it. There's a product they're forced to take, given generous subsidies to take. They want it so bad, they don't want it so badly, they'll pay not to be on there. I can't help but think in Texas, there are many small business people, entrepreneurs, young people that are no longer on their parents' plans but still going to college, working their way up the economic ladder, who frankly now don't get really any coverage, who will have an opportunity with a credit to buy a plan that's right for them, for their business, for their family as well. And so I see coverage increasing for those today who have seen no hope in Obamacare's mandates.
I think this is a really important point that you make, and I want to stop and emphasize it. And of course, anybody's free to comment that wants to. But if you're on one, or if you've paid a fine not to be on the Affordable Health Care Exchange or system or whatever, we don't do anything to help you get insurance, right? You're just sort of out there on your own. In this situation, you are going to get something, a tax credit, to help you do something. If you don't like what's available there, you said, well, okay, you've got a better idea for yourself and you want to do it, we're going to help you get there. Now, we relate it to age and income to some degree, which I think is wise. Some people don't need it. There's a lot of people that, frankly, are fortunate. We wish there were more, but literally don't, they want to go get something on their own, they can write the check. But here, you're actually helping people that said, I don't like that. And you said, well, here's something to go build something that you do like with.
I was with Mr. Vice Chairman, I was with a small business person this weekend who can't afford the $1,200 or more a month for Obamacare. He's had to pay the fine. But when I described, with you and your daughter, the amount of money you would get, the ability to buy plans more tailored to your needs, he said, I'd give anything to have that option, because I don't have that today. I get no help at all. And so there are just a lot of those small business people, a lot of those students working their way into their first job, those early retirees or those anxious, 60 years old, and there's 5 long years to Medicare, who are anxious to have better choices than they have today.
Mr. Chairman,
we'll go around. I'll certainly give you.
Yeah, I mean, again, I disagree strenuously with Chairman Brady said. I mean, if you look at the CBO report, the reason why they say, I think it's 14 million in the next year will lose coverage, 24 over, in the years beyond that, is basically for 3 reasons. One is, as with those in the individual market, because the tax credit you're giving is paltry compared to the subsidy and the tax credit that we give in Obamacare, a lot of people now are going to have to pay another $4,000 or $5,000 a year for their insurance on the individual market, and they won't be able to afford it. So that's why many in the individual market lose coverage, and that contributes to that number of 14 and 24. With regard to Medicaid, as time goes on, fewer and states and the expansion is limited, and the cap and the block grant go into place.
Would you have to leave coverage?
Well, the point I'm trying to make is I'm making 2 points. The reason for CBO scoring of the loss of coverage is because the reduction of people on Medicaid, because of the lack of subsidy for people on the individual market, and also people who, because there's no longer a mandate, that a lot of employers will not offer health insurance. But beyond that, what I also disagree with is, the chairman is basically buying into this freedom argument that these people that, pay the penalty really don't want health insurance or maybe don't want the insurance that's offered. But that's, again, affordability issue. I mean, it's been 7 years. It was envisioned when we put this together 7 years ago that at some point we would look at those subsidies again and see if those subsidies needed to be more
I
generous.
think if I recall the CBO thing, that the employers that we're going to are 3 million people. That's 1%.
I think it's 7.
No, I think it's 3, but
But all
whatever.
my point is that these are not people that are choosing to pay the penalty and not have insurance because they don't want the
No,
insurance.
that's not the group I'm talking about, but I'm just saying this is, I mean, the majority of Americans get their insurance through their employer right now.
Right.
And so we're talking 7 million people versus 150 million people, and most employers realize, particularly if you're going to want long-term employees, there's certain benefits that you need to provide them, or you won't have them.
But
You won't have
the
people.
problem is that, insurance is a pool, as you know, right? As more and more people go off insurance, right, and the people that, are more likely to do it are the ones that, just for the various reasons I said, can't afford it anymore, then that insurance pool, shrinks. It gets to be more and more sickly people, older people, and then the premiums go up. So this is like a vicious cycle.
It seems to be what's happening to Obamacare right now.
I disagree, and I think the answer is to try to help people more with their subsidies, not say we're going to give them less of a subsidy, which is what you're doing.
Let me go to my friend, the chairman of
I
Energy
appreciate the vice chair. I think it's important to look at the CBO numbers because what they project is there'll be 4 million uninsured in 17, 14 million in 18, and 16 in 19. That all the Obamacare subsidies are in place through 19, all of them. Plus, there's additional support going to the states. They could buy down premiums and co-pays through the Patient Stability Fund. They get that money starting in 18. So there's 2 years where states will get $15 billion per year for those 2 years before any of the other subsidies go away. CBO took that into account and said, you're still going to have this problem. Well, that tells me you got a failing market out there. And we're doing nothing to bring down costs. And that's where I can assure the gentleman that the Energy and Commerce Committee is going to look at what's driving the costs up. Because as my friend from Kentucky said, we're only arguing about 5% of the market here. Everybody in America is being hit by higher cost health care. And it's from one end to the other. And I guarantee you, Mr. Vice Chairman and members of the committee and people watching, we're going to go after the cost drivers wherever they are. My degree was in journalism. I'm just going after the facts. And we're going to find the facts. We're going to shine bright lights on every piece of this. And we're going to find out what is driving the costs up to the point whether you're low income or high income, you're paying more than you should have to for your health care. We all get too many examples of people who spend a very little bit of time in a hospital and come out going with a $70,000 bill and wonder, what the heck is that for? Why is a box of Kleenex what it is? We've all seen those on bills, and you go, how is this the case? And so we're going after the cost drivers, I assure you. There are lots of programs in federal law that put a lot of money around and flood this swamp with a lot of high-paid folks. And we're going to figure out what's driving those costs, too.
I suspect that will be a much more bipartisan pursuit than maybe what we're dealing with today. It just, yeah, certainly. Yeah, oh, certainly. I'm sorry, Mr. Neal.
Thank you. But Republicans, Tom, frequently talk about personal responsibility. What's more personally responsible than buying health care insurance? Why should the rest of us be assessed $1,000 in our own plans to take care of those who simply refuse at 28 or 29 years old not to buy health insurance? Our proposal here is Richard Nixon's proposal. Our proposal here is Bob Dole's proposal. Our position here is Mitt Romney's proposal, that shared responsibility, offering discipline in the marketplace, would come best from the idea of trying to manage risk. More people in the risk pool, particularly those that are younger, who by and large tend to be healthier than those that are older, points to the whole notion of shared risk. So when do we buy homeowners insurance? After the house burns down? Or when do we buy automobile insurance? After the car hits the tree? I mean, I don't understand Republicans all of a sudden rejecting proposals all the way back to the Nixon years about the notion of personal responsibility in buying health insurance.
So may I respond to that?
Certainly.
Because while we do reject the issue of the individual mandate, we have a disagreement on that, we do support the issue of personal responsibility, and that's called continuous coverage, and that if you step out and say, I'm not going to play, and then you say, oh, well, maybe I do, you pay a penalty of 30% just on the premiums for that year, and there's a hardship exclusion and all that. So to your point, we just approach it a different way that's more individual decision allowed. You get to make that decision, but if you have pre-existing condition, we take care of you. And there's hardships, there's all these things. But to your point, you're going to pay a little penalty if you're not going to sign up for insurance. Because I've used the same example. You don't get to buy homeowners insurance when the roof's on fire. So we say, we'll protect you on pre-existing, but you pay a penalty if you wait until you're sick to buy insurance.
But again, the people don't drop out and lose the continuous coverage. For most of the time, it's because they can't afford to pay it. They get a different job. There are numerous reasons why people don't pay their bill and lose their coverage. And I don't think it has to do with personal responsibility at all. I think it depends with your circumstances and what happens with your income and your health. And I think it's very unfair.
My time, if I may, because the chairman's been very generous. I've had much more time because you guys take a lot of time. And we don't want to recreate all the debates in energy and commerce and ways and means and budget right here for all of us to go through again. But let me just end with this, just as an observation. Number one, with all due respects to my friends, the fact that there's more people that get exceptions to Obamacare or pay fines than are actually in the exchanges tells me it's not working very well. And fortunately, I'm going to finish my time here. I've tried to be generous with everybody. We are talking about a relatively small portion. It's an expensive portion, but it's a relatively small portion of the total population. Most people continue to get health care through their employer, on Medicare, or through classic Medicaid. That's the huge preponderance of this market. And the quicker we get through this and get to what my friend from Oregon wants to focus on, the better off the entire country would be. And because I think that's where a bigger problem. I'm not saying this isn't a problem. It's certainly a problem. And it's certainly a problem with pre-existing conditions. And I want to compliment my friends on the Democratic side. It's something they can take pride in. You may disagree with what we're doing now, but you deserve the credit for establishing the threshold that people with pre-existing conditions are going to be allowed to buy insurance. That's something that came out of the Obamacare debate, and we're keeping large elements of that plan. That some were related to it, some were added to it. So there's a lot of change here, but I don't think there's probably as much change as everybody suggests. If 80% of the country is going to continue getting insurance exactly the same way it does. And we're trying to make sure everybody has something to build off of, which they don't now. And we're going to protect people with pre-existing conditions in a different way, but a proven way, a way that's worked before. I think, there's probably a little bit more desperation in this debate than needs to be. I suggest, again, once we get through it, and it will change, this product will change, as everybody here knows, and we get on to these other questions that my friend from Oregon wants his committee to focus on, we'll actually do something in addition to this that I think will be really meaningful and really good for everybody and probably will be bipartisan. But in this case, we've got to work through it because I agree with my friends on my side of the aisle. This system isn't working. It's certainly not working in my state. When the rates are going up 69% and we're down to one provider and we're not a Medicaid expansion state, it's not working for us. And so this alternative, to me, for where I come from, is a whole lot better than what we got, and I think it'll continue to improve through the process. For that, Mr. Chairman, you've been very generous. The committee's been very indulgent, and I yield back.
Mr. Chairman, thank you. The committee does intend to take the time necessary to debate the bill, understand the bill, and make sure that every single person has that chance. If I could, I'd like to say that both the gentleman and the gentlewoman who've addressed this issue, the gentleman from Oklahoma has a strong content, which I agree with, and it is to the tribal nations that are around the United States, and his insistence to make sure and watch to make sure that they're properly dealt with. I also, and the gentleman, Mr. Brady, and the gentleman, Mr. Walden, are very aware, I am equally faithful to the disability community. I think every member of this Congress is aware of where I am on disability issues and very concerned about that and will continue to believe that we will, if necessary, come back. The gentleman, Mr. Walden and Mr. Brady, were asked about that, would continue in their roles of oversight to continue looking at tribal issues and implementation and disability issues. And if the gentlemen do agree with that, now is their chance to say that they do agree with that, because I'm hopeful, Mr. Brady, that you would agree that part of your follow-up of oversight of this would include our opportunity to make us aware of that. And I thank both of you for saying that. Without objection, I would like to enter into the record a policy. The National Physicians Council on Healthcare Policy has issued a statement in support of the bill that we have here today. Without objection, I'd like to enter that into the record. Secondly, Mr. Chairman, I'm going to have Ms. Booth, our clerk, give to Chairman Walden a amendment that I would like before he exits today, probably last, if he could please address this. I'll try and remember to do that. Yes, sir.
You have a copy of what
Yes,
you
sir.
entered
We'll get
into the
that to
record?
you, but we'll do
All
that.
right.
And
Thank you,
thank you
sir.
for the request. The gentleman from Massachusetts is now recognized.
Thank you, Mr. Chairman. Since we're inserting things in the record, let me insert the AARP's strong opposition to the Republican bill. I should also say, as my colleague Congressman Neal pointed out, that there were Republican governors that are very concerned about the Republican bill. I'd like to ask unanimous consent to insert the letter from Massachusetts Governor Charlie Baker, as well as from the Republican governor of Michigan, Rick Snyder's letter into the record. They have some very deep concerns about this. You know, and I want to, I guess, my first question is about process. And while I appreciate the chairman of the Rules Committee saying that, you know, we want to have a robust discussion here in the Rules Committee, to be honest, the robust discussion on it have occurred in your respective committees in the form of hearings on this legislation. And I'm just trying to understand why there was a decision made to do no hearings on the actual text of this bill, because, you know, the details are important on this. We can have hearings on general issues, what's working and what's not with the Affordable Care Act, but quite frankly, language matters. Legislative language matters. You know, I heard Mr. Walden, when he opened up, said that this bill would be good for the people with disabilities, and yet I got a letter here from the National Disability Rights Network strongly opposing the Republican bill. We have letters here from the Chronic Illness Disability Partnership. Lots of different organizations signed on opposing this bill. The Consortium for Citizens with Disabilities. I mean, I'd be here all day if I were reading the different organizations that strongly oppose this bill. I want to ask unanimous consent to put those in the record. He also mentioned that you know, the Republican bill is good for rural communities. I have a letter here from the National Rural Health Association urging a strong no on this bill. I respect the members of this panel, but I also have to say, with all due respect, that you all don't know everything, and neither do I, and that's why you do hearings. And so I'm trying to understand the mad rush to get this thing done tomorrow without CBO scores, without hearing from members of the disability community, without hearing from the American Hospital Association, without hearing from healthcare providers all around the country. Can somebody explain to me why this is a good process to bring this bill to the floor?
Well, if I may,
Yeah, absolutely.
Mr. McGovern, I can speak to the Ways and Means approach, which was far more open and transparent than our Democrat predecessors brought to us. I was there the night before the markup in Ways and Means, where we were delivered last minute a 800-page bill that frankly no one in that committee had read. And then nearly midnight, we were given a 300-page manager's amendment, no score, no explanation. We began voting at 9 o'clock.
Well, if I could reclaim my
morning.
time for 1 second here, just to set the record straight, because I'm not into revision. We don't have a lot of time here for
Yeah,
revisions
but
history.
this is
But
accurate,
excuse me, I
Mr.
have the time, and I'm happy to yield to you. But the House held 79 bipartisan hearings and markups on the Affordable Care Act in 2009, 2010. House members spent nearly 100 hours in hearings. Hearings are different than markups. Heard from 181 witnesses from both sides of the aisle, considered 239 amendments, both Democratic and Republican, and accepted 121 amendments. In markup, Energy and Commerce Committee adopted 24 Republican amendments. In markup, Education and Workforce adopted 6 Republican amendments. The original House bill was posted online for 30 days before the first committee began their markup, and more than 100 days before the tri-committees formally introduced their merged bill in the House. The House Democrats posted their first House bill online for the promised 72-hour review. The Senate bill voted on the House in the House was online for 3 months, and the reconciliation bill was online for 72 hours of review before final vote. House Democrats heard and answered questions from constituents at more than 3,000 healthcare town halls of public events, and tens of thousands of emails, calls, letters were logged in the congressional offices to register public comment. So I guess this is not, I'm not going to say that this was a perfect process, but I'm simply saying compared to what you're doing, it is a much better process. I just want to know why no hearings.
So, after all of that said,
Yeah.
Speaker Pelosi resorted to pleading, you have to pass the bill to find out what's in it.
And that is the answer
After
to why no
all of
hearings?
that, and so let me just
Yeah.
tell you, on the Republican side, we've held nearly 200 hearings on these
On
measures.
on this bill?
Yeah, on the provisions and elements.
No, I
of
didn't
this
see this bill until March 6th.
And if I may finish, this bill also includes 37 pieces of legislation that have been considered by the full House of Representatives and approved in the past. It includes the elements that were created and unveiled last summer in the Better Way healthcare replacement. And as opposed to Democrats handing us 1,100 pages of proposed law in the Ways and Means hearing, we gave, with full 2 days' notice, our 50 pages, easily understandable, transparent, and we held a 18-hour markup in which every amendment
No
was
hearings.
considered and everyone was
No
allowed to
hearings.
speak. And so if you don't know what's in this bill, you have no one to look at but
right,
the
so-
one in the mirror.
I yield to the gentleman from Florida.
First off, and I thank the gentleman for yielding, that's not how Congress works. This stuff is hard, and all of us know it's hard. So when something fails, we start over. And when you start over, you have hearings, and you hear from different people. 7 years ago, or indeed 8 years ago, or in the run-up to the Affordable Care Act, we didn't have all of this cockamamie technology that we have nowadays. We didn't have the ability for people to flood us with emails and all sorts of things that are changes or that have occurred. Not to mention the various organizations, including those that Mr. McGovern has introduced in the record, and the one that has 500 physicians that the chairman introduced into the record. All of those things have changed considerably in that period of time, and that's why you should have started over.
Right. I thank the gentleman. I would also just point out, some of your own members, Mo Brooks says the health care bill's rollout was not indicative of an open process. Justin Amash says this place may have been more open under Speaker Boehner, sadly. We should have an open process. Let me ask you, Mr. Walden, how many hearings have you had on this bill since you became chair?
Well, first of all, I appreciate the question. We went into markup, but let's go back and look at you're comparing apples and oranges.
No, I'm just asking,
You're
it's a
comparing
simple
apples
question.
and
How many
oranges.
hearings
So
have you
if
had
I
since
could
you were
please-
chair?
If I could please respond.
Okay.
So actually, we had hearings on some things that are in this bill. There are provisions that Mr. Burgess chaired a subcommittee hearing on that are in here. Other things came to us, but remember, you're comparing what you all did with the ACA versus reconciliation. We're dealing with a reconciliation bill
I'm
here.
just
Let me
asking a
give you the
simple question.
record
How
of
many
what.
hearings have you had on this bill that
So
we are
on
now
record-
considering since you were chair?
So on reconciliation, last time the Energy and Commerce Committee waived and all the things got shoved in. There wasn't even a hearing, let alone a markup
so
on
does
reconciliation.
that mean zero?
So we
Is
did
that
not
zero?
have a hearing
right,
specifically
thank you.
on
That's
this
the
one. That's a
answer to the
matter
question.
of record.
Yeah.
But we did have hearings
That
on
was-
issues involved.
You answered my question. None. Mr. Neal?
Mr. McGovern,
Use the mic. Yeah.
Mr. McGovern, the healthcare markup and the hearings culminated in a 14-month process. everybody who was on the Ways and Means Committee was almost tired, if not exhausted, from the amount of witness testimony that we took. And I also hope that Mr. Cole is going to have a chance, if he addresses the Republican conference today, to point out that about 80% of what you're doing is Obamacare. I think that considerably would help our argument as you bring the matter to the floor. And I hope that the evidence that we've presented here on the number of hearings, town hall meetings, 3,000, and the number of hours that were spent in the United States Senate, they were in 25 days of consecutive meetings on the Affordable Care Act.
Mr. Chairman, could
Yeah,
I just briefly, there were no hearings. We got the bill Monday night late, and the markup started Wednesday morning. And you know, the Speaker, Ryan, kept saying this was going to be regular order. I don't know how many times on TV or in the media he said this was going to be regular order. Regular order in our committee would mean that the Health Subcommittee would have a hearing. Dr. Burgess is the chairman of it. The Health Subcommittee would then have a markup, and then the bill would go to the full committee for a markup. And I would point out that the Health Subcommittee has had at least one hearing per week on other topics since January when we were sworn in. So there was ample time. They could have had a hearing on this as opposed to all the other things they did.
Yeah. Ms. Black, same question to you. How many hearings has the Budget Committee had since you've been chair of the committee?
Mr. McGovern, our role and responsibility in the Budget Committee is in the reconciliation process. And so we follow the reconciliation process, sir.
So no hearings, right?
Well, the reconciliation process is a process and not hearings.
Right. And let me ask all of you, how many witnesses from the current administration have ever testified before your committee on this bill?
Well, as Chairman Black pointed out, in the reconciliation process, we don't talk, we do. And in this case, the House bill before you today is the result of much hard work, including Dr. Price, the Secretary of Health and Human Services, who, along with other committee chairmen, developed the Better Way agenda and this bill in front of you.
Well, that's the most incredible thing I think I've ever heard in this committee, that you know, I mean, the idea that you are rewriting healthcare law that is going to impact millions and millions and millions of people, and we're just going to do it without listening to anybody, without taking testimony.
Nearly 200 hearings, Mr.
No, not on this bill.
On the
Not
elements of this
Not
bill.
on this bill. This bill was made, this bill.
Gentlemen
You're-
yield for
you're
a question?
mistaken.
Yeah, you have to do a question, yes.
I appreciate it. Wasn't the Affordable Care Act actually passed under a reconciliation bill?
Yeah, elements of it.
And did we ever have a hearing on that?
And to the
There were a lot-
gentleman's
there were-
point, not only didn't you have a hearing, the Energy and Commerce Committee was excluded from the process. It came
I
up
think
for
final passage
budget,
was on
and things-
reconciliation.
We never had a hearing, let alone a
I would say my
markup.
time, Mr.
And the
Malone.
House was passed with
Mr.
10
Malone.
minutes of debate. The final bill with 10 minutes of debate.
Not my time. I'll yield
2,400
back to
pages.
my friend. And
The reporter can't record people talking over each other.
Well,
as I recall, it was a reconciliation.
let me, let's.
But we're, to the point, I mean, we're on this, and it's the
So let me
gentleman's
ask,
time.
so let me ask a different question to Mr. Pallone, Mr. Neal, and Mr. Yarmouth. How many Democratic amendments that were offered in markup were approved?
Every Democratic amendment was rejected along party lines.
Oh, okay. All right. Mr. Neal?
Every Democratic amendment was rejected.
Mr. Yarmouth?
We don't actually, in our process, introduce amendments that have changed the underlying bill. We offer motions to instruct the Rules Committee, which Chairman Black is going to present, but we offered 7 motions and none of them were approved.
So let me ask you, okay, all right, so here we have a bill that, again, had no hearings, and we're rushing this. What is the magic date? You know, I'm still trying to understand, what is the reluctance to, you know, to push this off a week, you know, to do some hearings or to, you know, wait for CBO scores? Or why is there, why does this, you know, what's the difference between today or next week?
I can answer
Yeah,
that.
absolutely.
So for 7 years, Americans have been hurt by Obamacare. I hear this from our small business people. I hear it from our Patients, yes, from our doctors and nurses. And they have pleaded with Congress to please get the government out of the examining room, give them health care they can afford.
Right.
And so I think these efforts to try to delay and try to continue this failed Obamacare experiment is over. It
Well, I
truly
think
is
with,
time to act.
I think with respect, I think even people who may be critical of Obamacare would like this body to be thoughtful in about how they proceed. And so if someone's watching this hearing right now and we're acting because, for political reasons or because we got to rush this to the floor because we just want to for the sake of passing a bill, I think most people, even people who may not like the Affordable Care Act, won't approve of that. I just want to say one thing. Before the issue of 24 million Americans losing their health insurance came up, I just want to make sure the record is clear why we say that. I think Mr. Pallone and Mr. Neal comment on it, but I think it's worth reinforcing here. And the reason why we get to this view that 24 million Americans will lose their coverage, we're talking about Americans working full-time in minimum wage jobs, home health aides, daycare workers, employers and local businesses who will see their coverage disappear as a result of the Republican plan cuts in Medicaid, and it also repeals income-based premium tax credits. We're talking about Americans who purchase their own insurance in the health insurance market, who will see their coverage evaporate as Republicans continue to sabotage the market, returning to the days when people with pre-existing conditions could be left without affordable coverage for mental health care, prenatal care, and prescription drugs, and even Medicare beneficiaries' coverage is in jeopardy as this bill would rob the Medicare Trust Fund of $170 billion, shortening its life by 3 years. So, I mean, that's why we are concerned, and I think that's why most Americans are concerned about what you're doing and why it's increasingly unpopular. That's why Republican governors are writing to us on this thing. I want to ask a question that Mr. Kennedy raised in the Energy and Commerce Committee, and I just to kind of put this in perspective. It's my understanding that before the ACA, parity laws said that health plans had to offer mental health coverage on par with physical health coverage to the extent they offered mental health coverage in the first place. Now, the ACA required plans to offer essential health benefits, EHBs, including mental health and behavioral health coverage for the Medicaid expansion population, which previously had been optional, thereby guaranteeing parity. This guaranteed that Medicaid programs provided not only an actuarial level of sameness in the level of benefits offered, but ensured that the quality and variety of different behavioral health treatment options was available to these individuals, along with important consumer protections like appeal rights included. Now, unfortunately, the underlying GOP bill would repeal EHBs for the Medicaid expansion population. That means people in the Medicaid expansion would no longer be guaranteed mental health and substance abuse treatment, along with all the other good EHBs. And then Representative Kennedy asked counsel in the Energy and Commerce Committee meeting about this, and I think that video got millions of viewers because it went viral. Now, the manager's amendment struck the language that repealed the EHBs for the Medicaid expansion population, which seemed like a positive move in terms of providing care for sick beneficiaries. Now, however, what I'm being told is that Mr. Walden's second-degree manager's amendment repeals that language, and in this amendment, the Republicans, as far as I can tell, are knowingly and purposefully rescinding guaranteed coverage of mental health and behavioral health services for low-income workers and families. And I'm just trying to figure out why. Mr. Pallone?
Well,
am I correct in that?
Everything you said is accurate, and I want to say two things about it. First of all, what happens when you don't have the essential benefit package, and the reason why Mr. Kennedy's making that point, is that states, because they're now getting less money for Medicaid, right, have to decide what to cover. And they don't have to cover everything because there's no essential benefits package. And, we know from the past that the thing that always goes and didn't exist before we had the essential benefit guarantee was mental health coverage,
Right.
a drug treatment, prescription drugs, because these things are very expensive. The other thing I would point out to you, because you raised this process issue, and there's been a lot of talk here about reconciliation. Fact of the matter is, this bill, gentlemen and ladies, is not really a reconciliation bill in the sense that there were many provisions put into this bill that because of the Byrd Amendment, because they're really authorizing things, will actually have to drop out. So when my colleagues on the Republican side, oh, this is a reconciliation bill, that's why we didn't need a hearing. Fact of the matter is it's not. There are many things in this that can pass here with 51 votes, but are going to have to drop out in the Senate because they are actually changing the authorizing language and don't meet the Byrd rule. So, I want to point that out because you talked about parity and some of these other things that came up, and things were put in by the Republicans that are Byrdable and are not part of reconciliation.
And I know Representative Kennedy will be up here later talking about this stuff. And again, going back to process, I mean, this was such a great process, and it's such a good vetting process that we have like 4 managers' amendments, each one correcting the other. Mr. Walden, am I misunderstanding what my interpretation of what your second-degree manager's amendment would do?
No.
Okay. I should.
But I should point out, if I may, that we all believe mental health services are important. The bill does remove the mandate on states that applies essential health benefits to Medicaid and alternative benefit plans. By the way, that is not dissimilar from what this entire Congress voted on unanimously under the PACE Act from Representative Guthrie a few years ago, passed unanimously. Mr. Paulus was a co-sponsor of that bill. Remember that on the alternative benefit plans for states, the option to enroll Medicaid beneficiaries in coverage is still benchmarked to Blue Cross Blue Shield standard provider plan under the Federal Employees Health Benefit Program, to the plan offered to and generally available to state employees, to the largest commercial health maintenance organization in the state, or coverage approved by the Secretary appropriate to meet the needs of the targeted population. This change does not remove the essential health benefits requirements for the private insurance system, nor does it change traditional Medicaid benefits. It's also important to know the provision does not change the federal mental health parity requirements established in the Public Health Services Act or in the Medicaid or CHIP. Removing these essential health benefits requirement for the alternate benefit plans does give states additional flexibility. And so I think you'd find that the Federal Employee Health Benefits Program standard option covers mental health benefits. Remember, this has to be benchmarked. That's one of the benchmarks. And a report from HHS in 2011 noted more than 94% of small group products in all state and federal employee plans examined appear to generally cover mental health benefits. Further, the Patient State Stability Fund, created by the proposal before us, provides states $100 billion over 10 years. Again, some of that money can be used by the states to help with mental health, to help with addiction treatment services, and a number of other acceptable uses. So we think we have coverage in here.
I just want to say that, the chairman mentioned the PACE bill. That was for a very small group market, and I think it's pretty sad, and he's basically admitting that, okay, we'll have these guaranteed benefits for all these other people, but we're not going to have it for those in the Medicaid expansion population, which is mostly childless adults. And those are the ones that often have the biggest problem and need drug treatment, need the behavioral health services. So I mean, to say that group of childless adults, which are the main people in Medicaid expansion, are the ones that are not going to have these guarantees, it's pretty sad, I think.
But remember, if I may,
I'll come back to you, Mr. Walton. One of the other things, for those of us who have our DNA in local government or in state government, this idea that governors are going to adhere to the mission statement of health care as allotted by the federal government to put those dollars in health care, that is not going to happen. They're going to use it to patch highways and roadways and bridges. They're going to use it to proclaim one year they have a surplus in the budget, and the next year to say that they're deficient because the federal government hasn't put enough in while they've used the money for another purpose. That's the challenge we have. Those of us in local government, we all know how that happens.
I want to ask unanimous consent to insert in the record a letter from the Mental Health Liaison Group, which expresses strong concern over the Republican bill that we're...
Without objection.
Mr. Palone, let me ask you a question. This bill will permit age rating of 5 to 1 for individual health insurance. That means that health insurance will become far less affordable for people age 50 or over. I think in the ACA's it's like 3 to 1.
ACA is 3-1, this goes to 5-1.
Right, right.
As
So-
Mr. Walton said
so-
states can make it higher.
Right, so in fact, yeah, so in fact, this bill, right, this bill will allow states to go beyond 5-1 and allow insurers to charge older Americans whatever they want. Is that your understanding?
He said that, Chairman Weldon said they could charge more, they could go to 6-1, or they could go to 2-1, but I mean, likelihood is they're going to go higher to 6-1, because that's what it was before we had this, before the ACA.
Yeah, I mean, it sounds like a prescription to make health insurance less affordable.
And look, the CBO said, that the reason they say they're doing this is because they want to get more younger, healthier people into the insurance pool. But the CBO actually said that that's not going to happen. What's going to happen is more of the people between 50 and 65 won't get insurance, and very few young people will sign up. So it's not even going to accomplish anything in terms of the insurance pool.
And does anyone have an estimate of how many individuals will lose coverage as a result of the bill's changes to age rating?
The CBO had that. I don't have it in front of me, but they gave that. That was a big part of why they said so many more people will be uninsured.
Yeah, I mean, because it'd be helpful to have an estimate of how the combined effects of age rating and the bill's smaller tax credits will impact the
That's in the
uninsured rate
CBO report.
amongst the older Americans. This bill, as from I could tell, I mean, even though we're being told that it's about repealing and replacing Obamacare, contains provisions. Some of the provisions would do that, which is why I oppose it. But the bill seems to go far beyond repealing and replacing the Affordable Care Act. It contains provisions that will reduce federal payments and shift costs to states and providers and beneficiaries and their families. In fact, the bill seems to be less about repeal and replace and more about capping and cutting Medicaid. And this is kind of a full-blown entitlement reform, if you will. Since we haven't had the benefit of hearings and since we don't have an estimate of the manager's amendments provisions from CBO, I would like someone to explain to me exactly what each of the following provisions has to do with repealing and replacing the Affordable Care Act. So Section 103 prohibits payments under Medicaid or CHIP to providers that offer legal abortions that are not paid for by Medicaid or CHIP. What provision of the ACA does this section repeal?
Well, I don't think anybody said at the outset that we're only dealing with Obamacare repeal and
That's
replace.
what when I hear you guys all on TV and I hear the president, that's what we're saying. I mean,
Yeah,
I'm just
so
trying to
we're
understand
trying to
what
fix
this
a
has.
broken insurance market,
Yeah.
and we're trying to
Well-
make sure that people have access to
Well,
care.
but-
So
but-
part of
but-
that is making sure places like in my district that have far more federally qualified health centers get funding as opposed to a very limited handful of other clinics.
Well-
And so we're trying to put money out into those. I have my district's
Right.
multiple times the size of your beautiful state. I can
This-
put it in one county.
And I would point out, Mr.
So we're
McGovern,
trying
that's
to
one of the
expand
provisions
coverage out.
that deals with authorization and is birdable.
Section 114 repeals the 3-month retroactive eligibility requirement that has been in law since the enactment of Social Security amendments in 1972. What does this have to do with ACA?
Nothing. And again, a lot of these are authorization changes that are not going to be able to be brought up under reconciliation.
Section 114
It
also
mirrors the
eliminates the
commercial
option for
market
states
requirement.
with high-cost real estate markets to adjust the $500,000 ceiling on home equity when determining eligibility for nursing home care. What does that have to do with?
Again, no hearing, another authorization.
I mean, Section 117 caps federal matching payments to states for all populations, not just those covered under the Medicaid expansion, and it does so in perpetuity, locking low-spending states into their 2016 base forever. What provision of the ACA does that repeal?
Nothing.
The bill makes a series of changes to the Medicaid expansion. 32 states have expanded Medicaid under the ACA, and more states, at least before this bill, were considering expanding Medicaid. But for states to make these decisions, they need to understand what the financial implications will be. So the text of the manager's amendment appears to allow states that have already expanded Medicaid to continue to receive the enhanced federal matching rate for those enrollees, provided that those individuals maintain continuous Medicaid coverage from December 31st, 2019 on. But what about new enrollees or people who aren't able to maintain continuous coverage? So could expansion states freeze enrollment for expansion enrollees and only cover those for whom the higher expansion match is available? Could this, in effect, put a freeze on coverage? Because that's how I read the language, and I would...
Well, in addition, I think it's very important you point these things out because remember, the Medicaid population more than any other population. These are the working poor under Medicaid expansion. And what happens is they're people looking for jobs, or they're changing jobs. And then, if they're not going to have continuous coverage.
Mr. Walden?
Well, there are two answers here. One is we don't put that freeze in place until January 1 of 2020, December 31st, 2019. By then, the tax credits are there to help people have flexibility to actually buy insurance. And if we get this into law sooner rather than later, we can begin reforming these markets, and maybe even this year you'll get reduced premiums out there in the markets. The insurers right now are trying to figure out what this market's going to look like and if anybody's going to come and rescue it.
Right.
That's why when you wrap the tax cuts, reduce the tax costs on the insurers, and you make these other changes, they think we can actually lower premiums this year, perhaps, based on what they would have otherwise
absurd.
been. And so, if I could finish.
No, I will. I don't mean to be disrespectful. Go ahead.
No, go ahead.
It's just that we're talking about real people here. This Medicaid expansion population, these are working poor. These are people making what, like $25,000 a year? They're looking for a job. They're changing jobs. Sometimes they have 2 or 3 jobs. They fall out of this Medicaid eligibility if they get an extra job at, a second or third job. What are we talking about? They're not going to be able to take advantage of these tax credits. They're going to suffer from the lack of because they're going to, they're not having a continuous job experience or continuous salary. I mean, we're not talking real life people here in my opinion, with this.
If I may, Mr.
Absolutely.
McGovern, we are talking about real life people here. There are huge coverage gaps in Obamacare. And I know of no governor, Democrat or Republican, who doesn't want to help people work their way off of Medicaid and into better paying jobs. To do that, it's critical that there be an immediately usable tax credit to buy a plan that's right for that young person or that individual, usually a small business person. Moving forward, that's why we work so hard along with our Republican governors to make sure this is a seamless approach to helping people work off the economic ladder. It's the tax credit. And the work that Chairman Walden did on the Stability Fund is exactly for governors like Mark Walker or Scott Walker in Wisconsin, who lowered the Medicaid levels, helped those people working their way off Medicaid with a private sector plan and the subsidy for that care. And he achieved lower uninsured rates than many states that had the expansion.
Yeah, the problem is
and
these
so
tax
this
credits
is
are
not
inadequate.
just
Yeah.
usable, it's proven.
Right, well, I think most people would say the tax credits are inadequate and there'll be higher out-of-pocket expenses. If I can.
Well, the
can I
gentleman
finish
yield.
Federal, I want to talk about the opioid crisis for a minute, if I could. I think everybody will agree that we're facing a new and serious problem with addiction to opiates. It's hit Massachusetts, I know it's hit a lot of other states, and we want to be able to deal with them. But I have some specific questions about how the bill will affect states' ability to respond to the opiate outbreaks. As I mentioned previously, the bill divides per capita amounts up among categories of people. So what per capita expense category in the bill will contain people who are addicted to opiates?
I mean, I don't think that has any reference to that.
Correct. It's not
It's
set
just
up
the per
that-
capita, and you get less money, and
So-
you kick the
No,
people.
So
if I can answer your
Sure, yeah.
question, there's no reference in Medicaid today that specifically pulls out opioids.
So since Medi-
So it's not right to say, well, there's no reference, because there's no reference today in existing law. But states would have more flexibility within their allotted funds. If they've got an opioid epidemic, you've got fentanyl coming and killing people, they can move money under this bill. They have that flexibility to go attack that problem, plus we have the
So
patient
with-
stability
with-
fund. that
With
would
your
help.
caps on Medicaid, lower Medicaid reimbursements, do you have any idea what the average cost of actually treating opiate addiction is?
Exactly.
I mean, it's
That's the whole
I mean-
point. The whole point is that that's the most expensive thing. That's why it's important to have essential benefit package, because if states get less money, then the first thing they're going to probably do is eliminate the most expensive things, which is drug treatment.
right. I mean, they're going to have to cut something or not
Mental
provide
health,
treatment.
drug treatment,
Right.
prescription drugs. Those are the expensive items.
I want to understand what the bill does to Medicaid eligibility for school-age kids. Section 111 of the substitute appears to repeal the requirement that state Medicaid programs cover children from age 6 through age 18 in families with income between 100% of poverty, which is $1,701 per month for a family of 3, and 133% of poverty, which is $2,263 per month for a family of 3. So Medicaid eligibility wonks call these kids stair-step kids because of the way Medicaid eligibility evolved over time. Based on research from the Kaiser Family Foundation, we know there were over 500,000 stair-step kids in 2014, and there are certainly more now. So I don't understand what this has to do with repealing the Medicaid expansion, which is for adults, but why are we picking on kids? But let's set that aside. So in 3 short lines of legalese, this bill, as I understand it, erases mandatory Medicaid coverage for these kids as of December 31st, 2019. And these 3 short lines do not say anything about what will happen to the coverage for these kids or to state budgets beginning in 2020. So if a state wants to continue covering these kids under Medicaid, can it do so? And can you show me where in the bill this is described? And if it's not in the bill, where is the authority?
So I can answer that.
Yeah,
What
okay, go ahead.
Democrats did was force kids off CHIP, into Medicaid. That's what you did when you passed the Affordable Care Act. What we're doing is saying, no, actually, states get a higher reimbursement rate under CHIP. They can put these kids back under CHIP, and they will do better, and frankly, the kids will do better under CHIP. And by the way, we're going to reauthorize the CHIP program this year because we believe in it. It's a big bipartisan piece of legislation going forward, and we think it makes sense to put them under CHIP where they belong, and states will actually get more reimbursement by doing so. It's a better place, a better way to take care of our children is under the CHIP program. You forced them into Medicaid where sometimes they get delayed access to care, which is the record of Medicaid because the reimbursement rates are so low, it's harder to actually get access to care. The studies all show that. So we think they're better to have children under CHIP.
Mr. Neal?
In reference to your question, between Medicaid expansion and S-CHIP, 100% of the children in Massachusetts are covered.
Let me just say this. I appreciate the fact that, my chairman is saying that he wants to reauthorize CHIP. It expires in September.
2017 it expired.
And hopefully, it will be as strong and it'll be as good. But understand, there's no funding for CHIP in this bill, okay?
Right.
We have no guarantees that the way CHIP operates and wraps around and fills in gaps, that's going to continue. So it's all very nice to say, just like they say, oh, the Senate will correct this, we'll do amendments, we've got, Plan 2 and Plan 3 down the road here. That's all very nice. But none of these guarantees are in this bill that you're going to vote on Thursday, if you vote on it. So I appreciate the fact that my chairman is saying, oh, we're going to reauthorize, it's going to be partisan, everything's going to be beautiful. But forgive me if not necessarily believing that and focusing on what this bill actually does, and it doesn't provide the funding for CHIP.
Well, anyway, I appreciate the answers to my questions. I'll just close by saying I continue to believe that this is a terrible way to proceed, a terribly flawed process. I mean, the people who know best about our healthcare system weren't even asked to come and testify in a hearing because we had to rush this thing so quickly. And appreciate the fact that we can use Washington speak and say we've done hearings in general on this or that over a period of a few years. The bottom line, we just got the text of this bill, I think, on March 7th. And I just, I think that's why that's what you're seeing reflected in some of the polls. The people are losing confidence in this institution because, I mean, we're not adhering to regular order. And this is a big deal. I mean, the idea of 24 million Americans losing their health insurance, that is a big deal. And it just seems like it's no big deal in this majority. And I regret very much that we're going down this path, and I hope this bill loses. And I yield back the balance of my time.
The gentleman from Georgia is recognized.
Thank you, Mr. Chairman, and I appreciate you all making it to witness number 3 on this side of the aisle. I wanted to start by talking about things we agree on. Mr. Yarmouth, I enjoy serving with you on the Budget Committee. You're a great ranking member. You challenged the way I think over there. What I thought I understood you to say earlier today is that you do see problems that need to be corrected, but we don't need to change the system for everybody in order to correct these problems. Did I understand you correctly?
You absolutely did.
And Mr. Neal, I thought I understood. Well, I've got your own question. You have your very own. I thought I understood you to say that one of the things that your state has most appreciated is the way that a Republican governor and Mitt Romney and a Democratic legislature worked together very collaboratively and came up with a solution that's working well in Massachusetts.
Coupled with the Chamber of Commerce.
Coupled with the Chamber of
And
Commerce.
the AFL-CIO.
Absolutely.
And, can I follow up with a question,
Please.
Mr. Woodall? And with help from the Heritage Foundation for the mandate.
I value both of those. Value both of those observations. I was not here in 2009 and 2010, but my frustration, and the one I hear from folks so often, is, Rob, folks identified a very real problem with the uninsured in America. And instead of working collaboratively to solve a problem that we all agree needs to be solved, we instead changed the system for everybody, and we jammed it through in a purely partisan manner. To be fair, the opposition was bipartisan. It was the support that was partisan. I am the first to confess that it looks very similar to what's happening here in 2017. And I hope that the cure is going to be better than the disease. We have a real challenge here, holding each other accountable. I think about all that we agree on, all that we talked about in the Budget Committee on which we agree, all that I see coming out of Energy and Commerce on which we agree, all that I see coming out of Ways and Means on which we agree. And it seems like we're going out of our way to make this more divisive than it has to be. I agree with Mr. McGovern. I wish that the death spiral of Obamacare was not happening so fast, that so many folks in my constituency weren't losing coverage so fast, that the uncertainty was not so paralyzing to folks back home, that we could have moved more slowly in this process. We do have new members in this institution, and yes, we have held hundreds of hearings in the 6 years I've been here on how to repeal and replace Obamacare, but I wish the death spiral was moving slower so that we could have done better. That said, Mr. McGovern knows full well that H.R. 3590 came over here from the Senate with brand new language that the Senate worked out all by itself with no input from a single member of the House. There was not one single hearing held on that bill. There was not one single markup held on that bill. This committee was the only committee on Capitol Hill to see that bill, and it went directly to the floor of the House, having been examined by no one else. I don't think any of my friends on the other side of the aisle would argue that's the right way to move legislation either. But we know this. We know that we could do better here. We know folks could have done better there. I want to ask about what happens next, because I support this legislation. I support moving forward, but I don't think I can bring down health insurance costs without bringing down health care costs. We're talking so much about access to insurance. I have a family friend. He's a doctor in South Georgia. He says, Rob, I'm the only Medicaid doc in the county. Hand out as many new Medicaid cards as you want to. I don't have any more room in my waiting room. Boston, Massachusetts, longest wait times in the country. A study came out yesterday, 52 days on average, 109 days to see a family physician. What good is Massachusetts health care to my family if I've got to wait 3 months to get in the door to see a doctor?
Might I answer?
Please.
Mr. Woodall, it's, I think recently it was rated as the healthiest state in the country. And Governor Baker took full credit for it. I want to let you know that as well. And the argument you made just a couple of minutes ago, you're depending on the Senate to fix this bill and send it back to us.
Truth be told, I'd be happy if the Senate would pass the bill and move it on to the president's desk. I believe the Senate wants to fix the bill. I'm up here with my colleagues.
If they change the bill, can we get a hearing?
Give me just one moment. I sit here with my friends from Florida and Massachusetts, and they've both said regularly, Rob, I don't know what you're so upset about. The Affordable Care Act was the compromise. We wanted a single payer plan. This is the compromise. I would say to my friends on the left, the American Health Care Act is the compromise. I want more freedom. I want more competition. I want more personal involvement in healthcare decisions. This is the compromise. And so my great hope is that we're going to be able to build on that. But tell me from the Energy and Commerce Committee's perspective, Mr. Chairman. I was talking to a couple last week, Kim and Pete, and they're both in their 50s. Their children are grown. Their understanding is that they can't go out and buy a health care plan that doesn't cover pediatric care for children they don't have and maternity benefits for children they won't have. Is that true as we talk about providing more freedom and choice in the marketplace? That
One of the issues.
This group that we know is priced higher because they are more expensive to insure, is still going to have to buy benefits they don't need?
You know, you've raised a series of really important points, and I appreciate your passion and your intellect on these things. You know, if I could go to one thing before I get to that, when I met with Governor Baker and a group of Democrat and Republican governors, he said to the group that what they had with Romney Care is different than what ACA is, and I think you'd have to admit that. And he said what happened when Obamacare came in is they saw an increase of 7% in their Medicaid population and about a 7% decrease in their individual insurance population. He said it was kind of a mix. They sort of went from here to here. The result for Massachusetts, I believe, and maybe Dr. Burgess would remember this as well, was I think $1 billion or $1.3 billion added costs in Medicaid, which they're a 50-50 match state, meant $1 billion or $1.3 billion cost increase for the federal government. Now, I'm sure there's some natural transition here and there, so it probably isn't all ascribed to Obamacare, but that was one of the points he made. And the irony is this was a state that was doing it on its own. This is what our states are, laboratories of innovation given the opportunity. And he said at the end of the day, they had 97% coverage before Obamacare. You got about 97% covered now. It just, he saw a cost shift occur, and it went to the back of the taxpayers. So going forward, what are we looking at? I want to know why EpiPen became so expensive all of a sudden, and the injector for naloxone became so expensive. How do we get competition into the pharmaceutical world? By the way, the president has spoken out on this issue as well. We're looking at a bill that will be on the House floor very soon on association health plans. When I was a small business owner, we paid 100% of the premium for the people that work for us, but we had 15 or 20 people working for us. I had no market power. As a radio station owner, I always wanted to group up with like people and get market power and put pressure back on the insurers so I could negotiate. I couldn't do that as a small business owner. So association health plans, I think, is really important. I think being able to buy across state lines. You know, we're working on legislation to do that. And I want to look at the cost drivers. There are a lot of embedded programs where a lot of money flows into the healthcare system. We want to know what happens to it. The GAO has figured out there's $36.3 billion last year alone in Medicaid of improper payments. Improper payments. It's on the high-risk list, and it has been for, I think, 14 years. They can't figure out where this money's going, but they know it's not going to the right places. Think what you could do with community health centers with $36 billion. I mean, this is year after year after year after year. In Medicare, there's actually higher misplaced costs. So we're trying to figure out what's driving these costs. Because back to Mr. Yarmouth's point, we're dealing with 5% of the market right here, roughly. What about the other 95%? They're paying these unfortunate, unnecessary high costs. And so I've asked our oversight and investigations team to begin the process of drilling down to figure out where these costs are. We bring down costs, we give more choice. The flexibility that my colleague from Ways and Means Committee is giving with HSAs and all for a different group of people really will matter. You know, when we did Medicare Part D in the Energy and Commerce Committee, we went through a lot of these same arguments. And we said no to all the things you're hearing today we should do. We said, no, we're going to let the market work. You know what? You want to talk about a market with satisfied customers? 85% of seniors say they like Medicare Part D. They have lots of choices. The cost to the taxpayers is 52% less today than what the Congressional Budget Office said it would cost. So if you have faith and create a market in the right way and empower consumers, they're the most potent faction to drive down costs, but you have to give them choice. And right now, in the individual market, choice is fleeing. You down to one choice or no choice. How is that productive? And their idea is just keep going that direction. Everything's going to be fine. They didn't offer any major reform amendments. I'd ask them, what do they think's wrong with Obamacare today, if anything? And where are your amendments to fix it if you think there's a problem in the individual market? And so I think what we're doing here really matters. What we're going to do going forward, I hope, will be bipartisan, like it was on 21st Century Cures, like it was on opioid, like it was on mental health reform. These are all things that really matter to the people that we live among, that are next to us, that are our constituents. Getting health cures, getting mental health, dealing with this opioid issue, getting at fentanyl and its illegal importation into the country, helping people with mental health services. These are all critical to us.
You make an important point, Mr. Chairman, and I regret that sometimes it sounds like when folks tell me they've watched a hearing on TV, it sounds like we're talking about who cares and who doesn't. And I reject that. I absolutely do. We all care, and you display that for us. But could you answer my essential benefits question? We know that older Americans are in the highest cost insurance of their life. They might rather buy a plan that's more generous on prescription drugs and less generous on pediatric and maternity benefits. Is that?
So basically, that's what the Guthrie Amendment allowed in the small market, or the small business market, if you will, the 1 to 50 and 1 to 100, was that flexibility away from the government mandated benefits. We ratchet that way down here, get rid of the metal tiers, the bronze, the silver, the gold, the platinum, but we we do that, and then on the expanded Medicaid, we do away with the essential benefits. For Medicaid itself, they remain, but we reduce the amount that the government says you have to put into each of those to give some flexibility so they can design plans that people might actually have to fit their need and their lifestyle and their budget.
Can I respond to that?
I hope we'll have a chance to continue to look at that. Mr. Blum?
Well, look, first of all, I think that, and I had this discussion with Virginia Fox many times before this committee. She's not here anymore. I kind of regret that, but because I enjoyed those.
She regrets not being here, too.
I enjoyed those. But this idea that we should go back to skeletal plans, as I call them, where people choose, whether they want hospitalization or they want maternal care, whatever, I think it's a huge mistake. I mean, first of all, you talk about freedom of choice, but it's not like, it's not like religious freedom or freedom of assembly or something of that nature. If you want to have a fair market with an insurance pool where, people are paying a fair rate, you can't let people pick and choose, because it's going to have the same effect of, if you don't cover a lot of people. It's going to increase costs for everyone else, because the person is going to say, oh, I don't need that. And then, if for some reason they do need it and it's not covered, then everybody else has to pay because they didn't provide the coverage, just like those people who are uninsured. But I would also point out, with regard to Medicare Part D, remember the ACA plugs up a lot of the problems that you guys didn't address with Medicare Part D. We get rid of the donut hole, for example. And I will point out, again, to his credit, that this bill does not get rid of those things. So again, you can talk forever about how great Part D was, but again, we plugged those holes up. We made it possible under the ACA so that seniors had the prescription drug pen, and thankfully, that's not being repealed here. But let's not talk about how great Part D was, because there were a lot of things that were left out that we corrected.
You wouldn't have had a donut hole there if we hadn't have passed it over your vociferous objections.
I understand.
Can I comment on that?
Mr. Neal?
Yeah, I will, and you're right. But give us credit for fixing it immediately and then saying it's worked.
Well, I'd like to give us all credit for passing HIPAA in 1996 in a collaborative, bipartisan way. We don't have hearings about how to repeal the pre-existing conditions exclusion in HIPAA. We don't have hearings about how to eliminate the fact that folks who don't play by the rules have a 2-year time frame that they can get back in and get themselves right, because we did that together. And but behind the closed doors, I hear about so much that we can do together. And I show up to these hearings, and it sounds very different. I'll close with this. I think we would all stipulate, both sides of the aisle, that we have 6 of our top healthcare experts in the Congress sitting here at this table, and I'm grateful to you for all the time you're going to give us. I can tell you I'm not a groceries expert, but I can buy milk for $3.49 a gallon at Harris Teeter right down the road. I'm not a clothes horse by any stretch of the imagination, but I can tell you that Joseph Banks will give me a good shirt on clearance for about $34, $35, best to buy on Black Friday if you want the buy one, get 4 free special.
Costco, yeah.
I don't know whether I paid the right price for my Mohs surgery here. Diagnosed with skin cancer, they had to, they get cut wider and wider and wider. It took off about half my face. I shopped it on my medical savings account, but I don't know if I got the right price. Do any of you all know what I should be paying for Mohs surgery today? I had to go in for a CT scan. I fell off my snowboard. I'm getting older and a little more frail. I shopped around again with my medical savings account. Mr. Neal, do you know what I should be paying in Georgia for a CT scan?
I will tell you this, when the diagnosis took place, you didn't care what it was going to cost to get it fixed.
Yeah. Well, truth be told, no. The diagnosis took place. I got on the plane, I flew back home. I didn't go to the emergency room when the headaches didn't go away. I went to the urgent care center. I didn't go from the urgent care center to the emergency room when they told me they couldn't take care of it. I went back home to get on the computer to deal with my medical savings account, and then I found out that the CT scan was $800 at the facility right beside me. But if I were to drive 25 minutes up the road, I could get it for $200. And I got in my car and I drove up the road. I was lucky that I had that flexibility. And I stipulate that emergency care, completely different. But I suspect for those of you with gray hair as I have, you can tell me what LASIK surgery ought to cost, because you might have priced it a little bit. Goodness for saving those dollars, Mr. Chairman.
The most newsworthy part is that you're a snowboarder. That's the thing that I take away.
The newsworthy part is claiming to be a snowboarder and getting the concussion all at the same time is all I can claim. We can't let that continue. I read every grocery ad every week when it comes out the door. I clip the coupons. The only reason I subscribe to the Sunday paper is to get the coupons when they come out. We cannot lower the cost of health care without having knowledge and skin in the game. McCarran-Ferguson is something that we've worked on collaboratively. Democrats have passed it when they've been in control. Republicans have passed it when they've been in control. We can do these things together, but I would just, because I have the benefit of being on the Rules Committee, I get the best and the brightest that you can sit here and visit with me one-on-one. I hope we can get to the transparency in costs. I know I can get my headache, my Excedrin with aspirin, Tylenol, and caffeine all combined into one pill, $2 a pill at Sam's Club. I can get the name brand, or a penny a pill at Ollie's with the off-name brand. But if I go to the hospital, they're going to charge me $10 a pill. Mr. Neal.
Thank you, Mr. Woodall. So let's take the mother whose child hits a fever of 104 degrees and has a seizure. When she drives into the emergency room or walks to the emergency room, the first thing she does not say is, how much is this going to cost?
Absolutely. Absolutely.
That's the issue.
But that's actually not the issue, Mr. Neal. The issue is when that mother has a child with a 104-degree temperature, did she have an opportunity to go to a primary care doc first? In your state, it would have taken 109 days to get the appointment. She has no choice but to go to the emergency room. Urgent care clinics, community health centers, great pilot project up in Philadelphia, New Jersey, there on the border, where they said our Medicaid population is missing their appointments. They can't afford the bus fare. They're not getting to the doctor. They built the clinic in the housing project so that folks would go there. They assigned personal care people to walk folks to their appointment to make sure they got the non-urgent care that they needed, so it didn't become an urgent care issue. There is so much that we can do together. There's so much success that we have had, and I regret that instead of celebrating some of that success today, we're still wrapped around the act.
Will the gentleman yield?
Mistake we made to my 45 years of living the life of caring about patients, the nurse and chairwoman of the Budget Committee.
And I have been sitting in this chair just wiggling, thinking, where do I insert this comment? But you are so right. We are missing talking about one piece that is actually funded by the federal government, is funded by state governments, and that is the federally qualified health centers, the Department of Health and the state and the local levels. This is good, simple, decent health care. And so we're missing that in this conversation. And it's a piece that as we start talking more about where people receive their care, that we've got to insert that in there, because this is simple, decent health care where you can actually find out what something really costs. And so I know that we're talking about this bill today, but as we continue, and Dr. Burgess can absolutely speak to this, as we continue this conversation about the cost of health care and what's available to people, there are other available resources that are coming both from local funding, state funding, and also federal funding that's got to be made part of this mix, because there are people, as you have already referenced, that have something right in the middle of their community that's good, simple health care that is a safety net that we're not talking about here. And I know Mr. Yarmouth also had a comment.
If the gentleman would yield, and I want to applaud Mr. Woodall, and he and I were speaking a few weeks ago, walking down the hall, and I think we solved the individual market problem. We had a similar solution. The question was, we wanted to call it different things, but anyway, there are solutions. But I just want to raise this point, and that is, when you talk about how we go forward. Let's talk about where we've been to a certain extent, because a lot of the problems that have been created over the last few years were the result of things that happened after the passage of the Affordable Care Act. One, for instance, the Supreme Court ruled that states didn't have to expand Medicaid, so 19 states chose not to. The other thing that's happened is that we set up mechanisms under the Affordable Care Act to create competition at the state level by funding co-ops, nonprofit co-ops. That funding disappeared, the indemnification that helped those co-ops go from loss situations to profitability. In Kentucky, our co-op, which was the most popular choice in the exchanges, more people signed up for insurance under the co-op than any private insurer, lost $60 million the first year, lost $6 million the second year, was actually on a path to profitability, and the safety net evaporated, and they had to give up the ship. So obviously, at that point, you took one of the biggest competitors out of the market. We also eliminated the risk corridors that helped indemnify insurance companies when they had adverse selection, when they had so many sicker people sign up than they would have anticipated. So we had mechanisms that would have helped sustain competition and create a better individual market, and those mechanisms were changed. So
I never talk about the Affordable Care Act without recognizing that that debate changed America, changed America's mind about pre-existing conditions in state markets, changed America's mind about lifetime caps, changed America's mind about keeping children on their policy till they were 26. I begin every conversation in that way because there are some things in there that can still define common ground. I guess I just wish, as we go through this very difficult process in this time, that folks would begin the conversation with, there really were folks who liked their plan and weren't able to keep it. There really were folks who were so unserved by the Affordable Care Act, they decided to pay a penalty instead of take the subsidy. There really are families in Tennessee who are down to zero insurers, families with serious pre-existing conditions who are going to be left with no choice whatsoever. And that we can come together collaboratively and fix that. I appreciate the work that my chairman and my ranking members have done. And without taking more time,
Can I
Mr.
just
Chairman.
say one thing? Because I know you mentioned the federally qualified health plans. I just wanted to say one thing. First of all, as you, I think, were alluding to, in the ACA, there was the biggest expansion that we've ever had of federally qualified health centers, not only in terms of numbers, but services provided. But the biggest problem that they're telling me right now is that in this Republican bill, because of the cutbacks in Medicaid that we've described today, remember, they get a lot of third-party reimbursement from Medicaid and to some extent from those in the individual market. And to the extent that those dry up and those people are not available, they will not have the money to continue to do the things they do. But I will point out that, again, in September, we're going to have to reauthorize the federally qualified health centers. So I hope that we will have support the way you're describing to do more. But right now, with this bill, they'll have less money because of the cutbacks in Medicaid, and that will negatively impact them.
You absolutely point out, Mr. Pallone, an area of broad agreement. I've been to every community health care center in my district. The most interesting thing I hear from each and every one is, Rob, don't give away health care for free. We have a sliding scale. Every one of our patients has skin in the game, and that is so critically important. You have to do more to help underserved communities, Rob, but you cannot make this a no skin in the game operation. You have to have folks involved in their own health care. And but like Chairwoman Black, they are dedicating their lives to serving the underserved, and I look forward to being your partner on that this fall. It's critically important, and I believe we'll get it done collaboratively and in a way that makes America proud. With that, Mr. Chairman, I yield back.
Chairman yields back. I would point out to Chairman Walden, you mentioned the Small Business Association health plans. That bill will be on the floor of the House this afternoon, so you will have a chance to vote on it this afternoon. Chair recognizes the gentleman from Florida.
Thank you very much, Mr. Chairman. Mr. Chairman, we've been here now 3 hours and 10 minutes, and I've had an opportunity to go to the facility, but our witnesses have not. And I would urge that it might not be unwise if we just take 5 or 10 minutes for them to be able to
Judge,
repeat them.
could I interject something there?
Sure.
We expect to break for votes in about 5 or 10 minutes.
All right.
So I hope everybody would be okay for that length of time.
We appreciate your
And-
compassion.
Yeah, I just trying to be nice about what I know are continuing problems. Or maybe it is that I'm 80 and the kidneys call more. You know, this nation is aging rapidly. All of us know the baby boomers are amongst us in significant numbers, like 10,000 every week. Following them are going to be the other generations who are aging as well. And somewhere along the line, that's going to be as much our responsibility and those that succeed us as anything. Before I carry on, my colleague from Massachusetts, I'd like to yield to him.
Yeah, because I just wanted to respond to something Mr. Woodall said about my great state of Massachusetts. One, I want to re-emphasize what Congressman Neal said, we're the healthiest state in the nation, so you should all try to be like us. One. Number two, you mentioned this study, so we just did a little exploration. Yeah, there was a study. It found high wait times, but its sample size for doctors, it called, in Boston, is between 9 and 20 offices. I don't know, whether you think 9 is a good sample size, but I just point that out to the gentleman.
Would the gentleman yield?
I'll yield.
Yeah. I would just say to my friend, I don't contest his numbers. If I would just ask that he also stipulate that this is a study that's been going on every year for the past decade, and that the leader of the Massachusetts Medical Society agrees with that conclusion.
But it also said that the same study found that doctors in Massachusetts, doctors accept Medicare at 100% acceptance rate, which is something that a lot of your states don't do. I just want to also say to him, I understand why the gentleman, given what we're talking about here today, would rather talk about an issue that has nothing to do with the underlying bill when it comes to transparency in pricing, which I think could be a bipartisan issue. But, you guys have had 7 years to come up with your repeal bill. If you wanted to put that in there, you could have put it in there. But it had nothing to do with what we're talking about here today. What we're talking about here today actually tears things down. It takes things away from people, takes health care away from people. And I think we got to focus on what this bill does. And we can speculate about all the other things we got to do. But we are dealing with a bill that has had no hearings and is going to the floor that will take health care away from 24 million people.
Gentleman will yield. Clearly, it sounds like.
I have the time, and I'll yield to the chairman.
Just 2 seconds. Clearly, it sounds like Massachusetts came together, developed a health care plan right for the citizens of Massachusetts, correct? So why are you denying other states the ability to do the same? That's what this Republican bill does. Gives states the flexibility designed both in Medicaid for the most vulnerable and to those small business people who don't have coverage today, health care that works for Texas and for Tennessee and for Oregon and other states.
Well, with respect,
So why
what
block them
you
from
would
that
do,
ability?
what you would do.
I'm going to take back all that
Just
time.
don't trust them.
Because
No, I was going to say,
getting out of hand.
if you pass this bill, you will hurt
just
people in
don't
Massachusetts
trust
as
the
well as
state.
everywhere else in the country.
Excuse
This
me,
is
I'll yield.
this is read the letter from our governor,
I'll
our
yield.
Republican governor.
Does
I'll
not
yield to
know
Mr.
best.
Neal.
Yeah, because the one thing that they do, Mr. Hastings, is they repeal the mandate.
Right.
That's why the Massachusetts plan worked.
Well, but that worked for Massachusetts. Wisconsin did not do the expansion at all and lowered their insurance rates more than the expansion states.
Well,
So
Mr. Chairman,
why deny
Mr.
the
Chairman,
states
reclaiming my
this
time, sir. Florida didn't expand Medicaid, and 900,000 people were left walking, and I can tell you that it would have made a difference. And let's make it very clear here. Among the reasons that the so-called Obamacare plan failed was because we did not work together, and your party continued the efforts to undermine it, and many, because of a political decision, states did not expand Medicaid, and therefore it was unworkable in many of those places.
Well, you're
and one
right.
of the reasons that all of the states, Mr. Chairman, I was told that we are going to recess, and I can split my time, But I don't want to.
Judge, how would you like to pursue the matter?
There's just two things to put on the minds of everybody here as we proceed.
Yes, sir.
My good friend from Georgia and I attended a bipartisan dinner last week. We had a lot of fun, and both of us the other day said that we had great enthusiasm during the weekend after having had that bipartisan dinner with other colleagues of ours. But we both agreed that when we got back here on Monday and came to the Rules Committee, our enthusiasm vanished. And it's going to get worse. Listen to the Constitution. We, the people, the preamble of the United States, in order to form a more perfect union, establish justice, ensure domestic tranquility, and provide for the common defense, promote the general welfare, and secure the blessings of liberty to ourselves and our posterity, do ordain and establish this Constitution. Now, my friends in the Republican Party, their mantra has been, since introducing this measure, talk about liberty and talk about freedom. It's as if those liberties and freedoms for all the people that advanced us here in the United States Congress did not have the same kind of underpinnings in their thought. But when you look at that liberty portion of the preamble, it's preceded by the overlooked often part of that sentence, to promote the general welfare. That's a part of our responsibility. And so when you talk about the freedom, and I love it, I asked one of my staffers to pull it up. I'm, as many of you, a lover of every kind of music. I like Bach, Beethoven, Brahms, Bo Diddley, B.B. King. I like them all. But I especially liked Janis Joplin, and I'm still wrestling with what she meant and what it must have meant to her. Let me give you the first paragraph of the first portion of Bobby McGee. She says, busted flat in Baton Rouge, waiting for a train, when I was feeling nearly faded as my jeans. Bobby thumbed a diesel down, referring to a truck, just before it rained, and rode us all the way to New Orleans. I pulled my harp out of my dirty red bandana. I was playing soft while Bobby sung the blues. Yeah, windshield wipers, slapping time. I was holding Bobby's hand in mine. We sang every song that driver knew. And then she says, freedom's just another word for nothing left to lose. Nothing. I mean nothing, honey, if it isn't free. I'm sure you all wrestle with this particular situation, but let me, at my age, older than everybody in this room, tell you something. We didn't always have health insurance in America. And it wasn't until the turn of the century that we did have health insurance. Interestingly enough, Germany, Russia, Hungary, several countries preceded us with health insurance. Our health insurance ultimately arose as disability insurance. And what we wound up doing in those days was everybody paid out of their pocket whatever they had. And that's how we proceeded. The tragedy is, at the turn of the century when we did get health insurance, my grandmother and grandfather didn't have insurance. My mother and father didn't have health insurance because insurance companies wouldn't sell insurance to black people. It was interesting, they would sell them all sorts of things. Street insurance, it was called, for life insurance. Now we come to where we are, and I chastise everybody in this room for us not working collaboratively to come up with a plan that can assist America. Mr. Chairman, I'd like to recess here, and then I'll tell the rest of what I intend for y'all to know about.
All right, Judge Hastings, I will allow us, we're going to go to recess here in a minute. We will start back with you.
All right.
Judge Hastings, and I want to thank you very much. For our guests who are also guests and witnesses, I want to thank each of you not only for your time. We're going to be subject to my call, but we're going to allow about 10 minutes after the vote to allow you time if you would like to go get a drink or something like that. But I would like to ask that all 6 of you please come back and be prepared as we move forward. I will also tell you, I promise not to talk about ZZ Top, but the band music is good up here, subject to the call of the chair at the end of the last vote.
All the doors. It's likely. All the doors.
Thank you very much for coming back after our vote. We're going to proceed with our first panel. The opportunity for us to keep the cadence going is good. I want to thank our 6 visitors who are here giving testimony for panel 1 to know how much we appreciate their time. And we're now going to move back to the gentleman from Florida, Judge Hastings, for his time that he would consume. The gentleman's recognized.
I say you have a little time. Thank you very much, Mr. Chairman, and I thank our witnesses. And Mr. Chairman, let me make it very clear that I compliment these chairs and the members of their respective committees. All of us, in my considered opinion, do extraordinary work on behalf of the American people, notwithstanding our ideological differences and our philosophical differences. But I'm going to start and ask when she finishes, Chairwoman Black, according to the score that we do have from the Congressional Budget Office, does, in your opinion, the Republican bill that we're considering here fulfill the promise made during his campaign by President Trump that, and I quote him, "We're going to have insurance for everybody, but it will be much less expensive and much better"? Does this bill fulfill that?
To the gentleman's question, I can say that our bill puts in place the mechanisms that will allow everyone to have access to health care.
You know, I anticipated that answer, and I leaned over a while back when someone else said that word access. I think you all have heard it now, and I said to Mr. Polis much earlier, we have access to BMWs, we can, and Rolls Royces, but we can't purchase them. So I appreciate where you're coming from. I'll take that as a no, that it does not do what Donald John Trump said, that we're going to have insurance for everybody, but it will be much less expensive and much better. So then we should update him and say we would have access. Ranking Member Yarma, according to the Congressional Budget Office, does the Republican bill lower premiums in the non-group market for everybody? And what about for people in their 50s and 60s?
Well, Judge Hastings, it actually increases premiums for most people in the individual market, according to the CBO. And for people in that age group of 50 to 64, according to CBO, the actual out-of-pocket cost on premiums, the difference would be somewhere about 6 or 7 times what it is under the ACA. Premiums would rise to about, for that group, would be somewhere in the neighborhood of $18,000 or so, and the subsidy from the tax credits available under the American Health Care Act would be about $4,000.
Okay, following up on that then, does the Republican bill make any effort to address the underlying reasons that health care is so expensive in this country? The one that we point to often is the outrageous prices charged for prescription drugs.
No, it doesn't, and I think that this panel has expressed itself very clearly on that, that's an area that we need to approach on a bipartisan basis. It's probably the single most important thing we can do to make the healthcare system sustainable.
Returning to you, Chairwoman Black, does the Republican bill extend the life of the Medicare Trust Fund?
I don't believe that there is a component in here that actually affects the Medicare Trust Fund.
Well, I do differ with you. I think that it takes $170 billion from the Medicare Trust Fund, and it shortens its life if you do that by 4 years. Do either of you have added information in that regard, Chairman Brady?
Well, I would, yes. So we chose with the rest of the nearly $1 trillion of Obamacare taxes that landed on consumers, on our local businesses, on our medical device companies, to also repeal the tax 0.9% surcharge went to Medicare for this reason. None of that lowered healthcare costs. Americans were promised by Democrats, if we tax this small business, if we taxed you for your health care plan, if we taxed you for having too good a plan, if Washington taxed that local business, your health care costs would go down. And it didn't. They've skyrocketed and continue to skyrocket. And so we made a conscious decision to no longer burden the American public and our local businesses with those failed Obamacare taxes. It did have a small impact on Medicare, but I still think, I listen to my local physicians, hospitals, and others, those $700 billion of Medicare cuts in Obamacare, frankly, have already done damage to
The little
them.
amount you're talking about, $170 billion, that's what you're talking about, and shortening the life of the program 4 years? Mr. Neal?
That is the provision, not the $700 billion of cuts in Medicare through Obamacare.
Okay, Mr. Neal?
But, Mr. Hastings, you recall as well that the ACA added 11 years to the life of the Medicare Trust Fund. And the proposal that we have before us today, according to CBO, and all the more reason why you need a CBO score, is it reduces the trust fund
Mr.
by 3
Walden?
years.
But it slashed Medicare reimbursements for our local.
Mr. Walden, currently, family planning services, aside from all the controversy that swirls around it, are a mandatory benefit under Medicaid. I saw some statistics that said that at least a half of the children born to poor women are covered by Medicaid. And this mandatory benefit requires all state Medicaid programs to offer family planning to beneficiaries of reproductive age. We're going to have to stop y'all from being on airplanes if you come out of a certain area with that kind of stuff. But anyway, states are required to cover these services like contraception and counseling and care because we know or believe, some of us, I certainly do, that they help reduce unintended pregnancy and also because they save taxpayers money. So in fact, for every dollar invested in publicly funded family planning services, an estimated $7 are saved in the Medicaid program. Now, aside from the 50% that I talked about children being born, about approximately 20% of women of reproductive age rely on Medicaid to access critical reproductive health, such as contraception, cancer screenings, and sexually transmitted infection screenings. However, it appears that the manager's amendment in its first iteration would no longer specifically require states to cover family planning services. Should a state choose to accept the block grant for their Medicaid population. Now, what impact would this have on Medicaid beneficiaries in states that choose to block grant their Medicaid program?
That would be up to the state to determine.
Okay, could women and, in many respects, disproportionately women of color, lose access to these critical services?
One would hope not. It would be up to the state to make that.
Gentleman have his microphone on.
Yes, I do, sir. It would be up to the state to decide the benefit package with some certain exceptions, including that pregnant women with children would need to be covered. There are some.
Well, wouldn't we want to give them some guidance? And if Medicaid beneficiaries no longer have access to family planning services through Medicaid, where are these beneficiaries to turn for this care?
Well, certainly the states would also have the Patient State Stability Fund. Some of these people might qualify for the tax credits, the refundable advanced tax credits, to be able to buy coverage that would provide for some of that. But again, I think states, just as we represent our constituents, the states are involved and pretty close to their constituents, and they would be able to make those decisions. I think they'd want to take care of their people.
Well, I had it in my deeper remarks, but I do want to deal with my governor, Rick Scott, and the failure to expand Medicaid. And also, I don't know whether you were here, Chairman Walden, or not, but I know that Mr. Neal and Mr. Pallone were here. We had a big controversy about Florida having Medicaid and the state doing exactly what Mr. Neal talked about just a moment ago, taking those funds and relegating them to the general budget. And so I would hope that, and Rick Scott may not be the governor by the time this is fully implemented, but I took umbrage with the fact that he didn't expand Medicaid, because I have, as do many of my colleagues in Florida, all over, Republican and Democrat, a significant number of people that were left uninsured. And it troubles me that we didn't deal with that. So if you block grant Medicaid, how would those 900,000 people be addressed if a governor chose to put money in the general budget or other aspects of the budget?
I think that's a really important question. It's one we would all be concerned about. States choosing the block grant are also required to submit a report that outlines the types of items and services, the amount, duration, and scope of such services, the cost sharing with respect to such services, the method and delivering of care. They have to submit that. A plan would be deemed approved by the Secretary of HHS unless the Secretary finds within 30 days that the plan is incomplete or actuarially unsound. So this ensures that states are not subject to the uncertainty and delays many have experienced with the waiver process, which, as you know, is quite burdensome. I know Governor Herbert out of Utah tried to get a waiver to allow him to email with his able Medicaid recipients, and 9 months later got an email from the federal government said he couldn't do it. He said that would have saved him $6.3 million rather than spending on postage. It'd be on email. Think what that could do to help the very people you described.
But then you have those mean governors that choose to do differently. And let me just highlight again Rick Scott. One of the hospitals in mine and Tom Rooney's constituency is in Belglade, Florida, or at least Tom Rooney's previous constituency. I don't know whether Francis Rooney comes over that far now or not. But previously, when this occurred, the governor visited that hospital in Belglade, and that's something all of us need to pay attention to. We talk about urban stuff, but rural stuff also is critically important, and that little hospital sees a whole whale of a lot of Medicaid patients. So he came for the administrators to show him the place. New hospital, everybody proud, spanking, shining, and all. And he made it a condition of his visit that they not ask him anything about Medicaid. And I consider that harsh, and the failure to have.
Chairman Yield?
Of course I will.
Is it true that Governor Scott sought to expand Medicaid in the state of Florida and was denied by the legislature?
You may know that to be the case, Mr. Chairman, but I don't recall that it was that way.
In defense of the governor, I believe that would be a true statement. And
all right.
I believe that the governor was trying not to bring forward a political argument for his visit because he in fact supported, in my opinion.
The buck stops with the person in the office.
Judge.
There's a portrait of Moses that hangs in the House chamber. And the words, "In God we trust," are displayed above the rostrum and on our money. And we open every session here in Congress with prayer. Yet how quickly we ignore the words in the Bible, a book many of us were raised to believe in, and in deference to the variety of religions here in our Congress, most of the parables in other religions reflect pretty much the same sentiment. I don't recall anywhere in my teaching Jesus talking about tax cuts for millionaires. He did say, render unto Caesar that which is Caesar's, and to the state which is their province. In the book of Mark, it said that, and the king shall answer and say unto them, verily I say unto you, inasmuch as ye have done it unto one of the least of these, my brethren, ye have done it unto me. And in the 41st verse, he says, then shall he say also unto them on the left hand, depart from me, ye cursed, or cursed, into everlasting fire, prepared for the devil and his angels. And this is the New Testament, our Old Testament version. For I was hungry, and you gave me no meat. I was thirsty, and you gave me no drink. I was a stranger, and you took me not in. Naked, and ye clothed me not. Sick, and in prison, and ye visited me not. Then shall they also answer him, saying, Lord, when we see thee and hungered, or at thirst, or a stranger, or naked, or sick, or in prison, and didn't minister unto thee? Then shall he answer them, saying, verily I say unto you, inasmuch as you did it not to one of the least of these, you did it not to me. I recite that for the reason that I began every one of my days hoping to be able to do something for people who are vulnerable. And somehow or another, I don't sense that this particular measure does that. And let me put a question to you all. If the taxes for wealthy people, and I think we all agree, reading this measure, that there are offerings for persons. I read something that said 400 of the richest people in our country will benefit to a relative degree under this bill. I'm fond of saying up here, I have 4 friends, 2 that are dead now, that are billionaires. And in my visits with them, they ain't worried about paying no little piddling taxes that we talk about here. And somehow or another, I don't think this bill is reflective of that sentiment in Matthew. And if those taxes that are in this bill stayed just like they are now under your bill, wouldn't that help more poor people than you're able to help under your bill? Mr. Brady?
Judge, my answer is no. As you know, these taxes were incredibly off the mark, so much so that Democrats and Republicans together delayed the Cadillac tax, the health insurance tax, and the medical device tax, knowing how damaging it was to the economy and the community and the working people you just referenced. Secondly, we know all those taxes didn't lower the health care costs for average Americans. In fact, they're seeing those premiums skyrocket, and my assumption is next year, the average was 25% increase this year. I wouldn't be surprised to see 35, 45, 55% increases because Obamacare is failing.
So that's $800 million, Mr.
No,
Brady?
so I think a key point you made, really important, is you want to see people who are working themselves off Medicaid in Florida have access to affordable care. And under the Republican plan, they will, because we provide them a tax credit. That single mom with 2 kids, $6,000 to help buy health care that's available to her, that would be good for her, that's not available to her today. And the state of Florida would have a part of a $100 billion stability fund from Mr. Wallen, Energy and Commerce, to help pay down premiums for the low income, the vulnerable, those with higher health care costs.
Well,
And so we
know-
address
know-
that population
We
you're
know
so
you know
very
your book,
concerned
but I
about.
also know basic arithmetic. And if the taxes that you are going to allow for those that are well off were to remain in your bill, I can't help but think that it would help others. Mr. Yarmouth?
It sure didn't work.
Yeah.
Thank you, Judge. A couple points. One is we had testimony before the Budget Committee earlier this year during a hearing about the Affordable Care Act, and this organization, I can't remember the name of the organization, had brought in some actuaries to calculate what the insurance policy would look like if they used a $3,000 tax credit, which under Secretary Price's former piece of legislation was the maximum tax credit that was allowable. And these actuaries calculated that the insurance they could buy with $3,000 would have individual deductibles of $25,000, family deductibles of $50,000, and would not include very, very important benefits like mental health and behavioral health and so forth. In other words, a very inadequate insurance policy. So when you talk about the alternative to Medicaid being the opportunity to use tax credits to buy insurance, the reality is that they won't buy insurance that is adequate for most people's needs. And the other point I would like to make is I would just like to nominate my governor to your list of governors who I won't call him mean, but I will call him not particularly sensitive to the Medicaid population. As many people know, Kentucky has had arguably the best experience in implementing the Affordable Care Act. Our uninsured rate went from 20% of the population to 7% of the population. 440,000 Kentuckians, which is 10% of the Commonwealth, now have coverage through the expanded Medicaid. Governor Bevin campaigned in 2015 to repeal the Medicaid expansion totally. That's what he wanted to do, basically to take insurance away from 440,000 people. When he was elected, and he could do it because Governor Beshear, who had implemented the program, did it by executive order, so Governor Bevin could do it by executive order also. Well, he didn't want to do it on his own, under his own name, so what he did was apply for a Section 1115 waiver. He wrote a waiver that he knew CMS at the time would have to reject, and he did that because he wanted to, on page 15 of his waiver, he said, if this demonstration project is not approved, I will rescind the Medicaid expansion, to wit, taking insurance away from 440,000 people. He knew it was going to be rejected. He wanted to be able to blame it on the Obama administration when he yanked all that coverage away. So lo and behold, President Trump is elected and appoints to head CMS the woman who actually helped him draft the waiver. So there's some kind of poetic justice. He's going to get his waiver approved, which is not very friendly to Kentucky residents, but that waiver at least is going to save 400,000 or so people their coverage. It will drop, according to the waiver itself, will drop 75,000 people from coverage immediately. So the point being that I would not trust Governor Bevin to be relatively compassionate in making insurance affordable and accessible to the Medicaid population if they lost their coverage.
Right, Mr. Wallen and then Mr. Pallone, and I'd ask you all to try to be brief because I have to be lengthy. Okay.
I appreciate that. Thanks for your courtesy. And I just had some additional information on your question regarding the block grants and one other point I wanted to make specific to Florida, if I might. Just to add in that the block grant must provide medical assistance for hospital care, surgical care and treatment, medical care and treatment, obstetrical, obstetrical and prenatal care and treatment, prescribed drugs, medicines and prosthetics, other medical supplies and services, and health care for children under 18 years of age. So there are some requirements there that
So
get
those are federal requirements that the
under the
state
block,
must
if they take the block
care.
grant.
I see. Mr.
Yeah.
Malone?
Can I just add the last part?
Sure.
And that is two other things, because I know you care deeply about Florida. Florida would actually get $39 million under the safety net provision in this bill of additional money next year for health care, and $1.6 billion under the Patient and State Stability Fund. So your state, if this passes, gets nearly $2 billion next year in help for people who need it in health care.
Well, God help us if the legislators that are there now get their hands on that kind of money. But go ahead, Mr.
I mean,
Malone.
to your question, and trying to be brief, the reason that these taxes, if you will, were put in place, mostly corporate and on the wealthy, were because we knew that if you were on the individual market and your income was lower, you needed a major subsidy in order for you to buy your insurance. And we knew that if your income was even lower, but in that area just above Medicaid, that if we were going to expand Medicaid, we would need to pay for the Medicaid expansion. What they've done with these, with the repeal of these taxes, is take all those pay-fors away. It was $1 trillion to pay for all that, primarily for the subsidies and for Medicaid. Other things too, like community health centers, a prevention fund, but primarily to help subsidize those on individual market and Medicaid.
Yeah.
You take that away, it's very simple. There's no magic in the CBO report.
Yeah.
The CBO report says you're taking those away, you're repealing those taxes, and as a consequence, all these people are going to be uninsured. There's no magic here.
I hear you. Mr. Neal?
Thanks, Mr. Hastings. A quick institutional footnote. I negotiated the device tax. It was proposed at 5%. I negotiated down to 2.3% with the industry. The industry's position was to apply the tax to foreign competition. That was the big deal. And remember that many of those devices are in fact sold to Medicare.
Right.
I mean, that's another part of the consideration. Now, if we could find that other pay for, I'm in. But the other point that you raised, I think, that's essential. Overwhelmingly, the taxes that are repealed in the Republican plan go to people at the top.
Will the gentleman yield
Yeah,
to that? So, I mean, in many ways, and you know that we'll get to this in my questioning, obviously, repealing the medical device tax has had a lot of bipartisan support. But in many ways, isn't it an illusory pay for it because of what you just mentioned? In many cases, it's Medicare that's paying for it. So isn't it in many ways taking money kind of from the entitlement side and moving it over to a different program? It's kind of a budget trick as much as it is a real pay for? Yes, sir. Okay.
All right.
Yield back.
Well, I do want to point out that every, or at least most of the members of Donald John Trump's cabinet will benefit from the Republican bill's tax cuts. It's reported that their known wealth is $13 billion collectively, and so they're going to be huge beneficiaries of this tax cut. The $170 billion that is being taken from Medicare's trust fund goes right into their pockets. The $157 billion tax giveaway on investment income goes right to billionaires like Donald John Trump's cabinet members. And let me correct the record. Reverend Collins evidently wasn't listening to me very carefully. I cited Mark when I should have cited Matthew. Yeah, all right. Well, I'm not going to ask any more questions, but I am going to end by saying several things that I think are pertinent. We still have not heard from the nonpartisan experts at the CBO, but we've received the partisan statement of administration policy. And, Mr. Chairman, with your permission, I ask unanimous consent that the administration policy be made a part of the record.
Objection, I'll be in.
Right. It's slightly longer than a tweet, at 2 paragraphs long. The first paragraph says, the bill, quote, begins to fulfill the president's commitment, unquote. And on what they call the failures of the Affordable Care Act. It begins. It then mentions in the administration statement, quote, patient-centered healthcare, unquote. I'm going to introduce later a statement from the nurses that, American Nurses Association, that says that nothing about their experience shows that there's any patient-centered healthcare on the ground that they work on, and I know your background, Ms. Black, as well. This is a phrase that it seems someone just made up because it sounds nice. Let me be clear. There's nothing in this bill about patient-centered care. You can try to spin it that way, and you can use fancy focus group phrases all you want, but this is an insurance company-centered bill. Footnote right there, I kind of laugh because the mantra, aside from liberty and freedom, has also been about the affordable health care being in a death spiral. I'm witnessing colleagues here, and I have lots of Republican friends that I chat with from time to time, but as y'all move this thing forward, you may not be in a death spiral yet, but you're sure enough whistling past the cemetery, and there's no question in my mind about it. The Congressional Budget Office says 52 million people will be uninsured in 2026. CBO says the value of your coverage goes down. CBO says the bill raises out-of-pocket costs. So there's your patient-centeredness. But insurers get a tax break for paying their executives more than $500,000. Now that's crazy. And they have a special tax cut only for people earning more than $250,000. On to the second and final paragraph of the administrative statement, where the administration relies on the mythical, at least according to members of the other body, two of them that are on record, Senator Cotton and Senator Cruz, and that's why I call it the mythical three-step process to repeal. Need I remind you about those persons and what they said? The administration statement closes by saying the president's senior advisors would recommend that he sign it. Now, I don't know if President Obama said he would sign the bill, the Affordable Health Care Act, when it went through our lengthy process, but I know that he did, in fact, sign the bill. So I'll just label this last sentence as interesting. At a time when you need to show the president's full support, it's interesting that the administration left the president some room not to sign this bill. Now, I want to briefly address the manager's amendment. Came out Monday evening sometime, and it was only by the time it got to the light of day that we had an amendment to the manager's amendment. And then, you know, the people in America must really wonder, do we speak, or as Jeffrey Lord said last night, Americanese, or do we speak plain English? This, to show you the fallacy of this thing moving fast, there's a technical manager's amendment already to the manager's amendment that was to the amendment that was already to the manager's amendment. Follow that if you can, people. The First Amendment corrects the drafting error and ensures proper labeling of subsections. The next three amendments correct an inaccurate cross-reference. The Fifth Amendment corrects a drafting error. This is now to this particular bill in the manager's amendment. And it goes on, and I won't bore you all, I already have, but if any of you are angry about it, it's deliberate, so you needn't come to me afterward. The amendment to page 66 inserts a missing word. So just imagine when we get through this and when it's massaged all the way through, had we taken our time, we might not have had to even do a manager's amendment, but for the fact that you have to clean it up for the New York crowd and other moderates and right-wingers and everybody else so that they can buy-in by Thursday. Mr. Chairman, I ask unanimous consent to introduce into the record the Senate Budget and Policy Priorities letter opposing this particular matter.
Without objection.
Additionally, I ask that the National Women's Law Center letter addressing this subject be made a part of the
Without
record.
objection.
They say, the amendment does not allow married parents of school-aged children or a child with disabilities to qualify for an exemption to stay home to care for their children. Perversely, both parents are then required to work and may not be able to afford child care. I cited earlier, Mr. Chairman, the National Nurses United. I ask it be made a part of the record unanimously, please. They say to eliminate the Prevention and Public Health Fund, which will worsen the health of our communities, spread infectious disease, and increase healthcare system costs. They say to phase out coverage for Medicaid expansion in Medicaid states beginning in 2020, while preventing new states from receiving enhanced federal medical assistance percentage in order to expand Medicaid. And then you also have a quirk, I believe it's Kansas, that their legislature is meeting now, and they're considering expanding Medicaid. I was going to ask you a question whether or not your bill exempts them, but I'll pass on that one and ask unanimous consent that the American Medical Association statement be made a part of the record.
Without objection.
Thank you, Mr. Chairman. Yes, of course.
Thank you. I just wanted, Mr. Chairman, earlier in this hearing, you inserted a statement in the record from the National Physicians Council for a healthcare policy.
That would be correct.
Supporting the bill. And that's interesting because maybe they changed their minds over the weekend because the chair of the council published a column last Thursday entitled "Fake Repeal and Replace Legislation Fails to Reform Healthcare." She says it doesn't address the problem, it exacerbates it. So I ask unanimous consent to insert in the record her very eloquent op-ed piece. Thank you.
Thank you. And the American Medical Association's first paragraph or letter directed to Speaker Ryan and Leader Pelosi, due to projections that enactment of the American Health Care Act will result in millions of Americans losing health care coverage, the American Medical Association must express our opposition to the proposal currently before the House of Representatives, and you've already allowed that it be admitted into the record. My friends on the other side of the aisle, and my friend and yours, the leader of their party here, but more specifically, the other side leader sitting in the White House, have had a lot to say about this bill. Donald John Trump told us that Medicaid would be safe under his, he didn't call it, I call it, Trump Care plan. Really? I don't think so. Under the plan pushed here today, Medicaid takes a devastating 25% hit, an $800 billion cut. Secretary Price told us that nobody would be worse off under what I describe as Trump care. Whether that, in my opinion, that's just clearly false. We've had Mr. Yarmouth point to the circumstances, and we've now heard ad nauseum about persons who are 64 years old that make a small income are going to pay more in their premiums each year under this disastrous bill. Hopefully, when and if it gets to the Senate, that they will correct that problem. Now, I've witnessed the fervor and the glee with which my friends across the aisle have whipped up their base over the past 7 years as they cried wolf over the American Affordable Care Act. And although I'm sure your base and I agree on very little, I sure think they're smart enough to figure out when their health care coverage options drastically shrink, as they will under this bill, and I know they will figure out that this plan has made health care less affordable for them and their children, and I know that they will come to realize the cruel reality wrought by this bill when they leave Medicaid for a couple of months only to try to to return, Mr. Pallone, try to return, because most of them that go off in the first place were having difficulty making any money. That's another thing, footnote there. Y'all talking about it making people go to work in places where there ain't no jobs. So I don't understand how that factors into this. And I know this, although we do disagree on much, all of them that I disagree with are my fellow Americans. And indeed, all Americans and patriots who that constitutional preamble that I read are adherents to the common defense as much as promoting the general welfare. Americans deserve, my friends, far better than what they're getting in this bill. I yield back.
The gentleman from Florida yields back his time. Thank you very much, Judge. I'm going to harken back here. If you have had time, the gentleman from Louisville, Texas, Dr. Michael Burgess, got your favorite chairman here, Mike.
Thank you, Chairman. Thanks for the opportunity. I will say that I do have plenty of time to talk about this in committee, and we'll have time to talk on the floor. So I'll try not to be as lengthy as you otherwise might think. I do feel obligated to talk a little bit about the historical perspective. Most of us on the Republican side remember when H.R. 3590 was passed by the Senate on Christmas Eve in the middle of a snowstorm when the senators were all trying to get out of town. 3590 was significant in that it was not the bill that we marked up in the Energy and Commerce Committee in July and August of 2009. That was H.R. 3200. H.R. 3200 indeed was amended in the three committees of jurisdiction. There were some Republican amendments that were accepted. It went to the Speaker's office. It was never seen again. A bill emerged from Speaker Pelosi's office. I don't even remember the number anymore, but it passed the House sometime in November of 2009. And in theory, that is the one that should have been conferenced with what the Senate produced. But what the Senate produced was taking a veterans housing bill that you and I had both voted for in July of 2009, H.R. 3590, and it was amended, strike all after the enacting clause and insert, and the and insert was the 2,400 pages of what we now know affectionately as the Affordable Care Act or Obamacare. So in truth, that bill, H.R. 3590, we had not had a hearing in the subcommittee or the full committee of Energy and Commerce. I wasn't on the Ways and Means Committee, but I suspect the same is true for there and Education and Workforce. So just a little bit of that historical perspective. And then to further this discussion, we all recall, in fact, I recall very well my chairman at the time, Henry Waxman, going on television and talking about after the Senate passed this bill, 60 votes they had in the Senate at the time, passed during a snowstorm, everybody's ready to go home for Christmas, and Mr. Waxman came back to D.C. fairly quickly and was preparing himself for the conference committee that was going to be assembled and work out the differences between whatever, I forget the bill number we had in the House of Representatives, and H.R. 3590, and there would be a conference committee and things would be worked out. But that conference committee never happened. And we all know the sad story. The Senate lost Senator Kennedy. He was replaced by a gubernatorial appointment who I don't think ran for that full term, but then the special election that elected Scott Brown was kind of a surprise, and no one really expected it to happen. So the 60th vote in the Senate was no longer there. And at the time, Majority Leader Harry Reid spoke to the Speaker of the House and said, "You're just going to have to take what we've passed. We can't do anything else." And I remember, I'm paraphrasing here, but I seem to remember the Speaker of the House saying something along the lines that, well, I don't have 100 votes for this damn thing over here. And that was, of course, in the middle of the month of January of 2010. It took 3 months until about this time in the month of March in 2010 to assemble those votes. But indeed, people were convinced along the way that they did need to vote for that, and the bill, in fact, did pass by the slimmest of margins. But remember what the bill was. The bill that came back to the House was, will the House now concur with the Senate amendment to H.R. 3590 as previously passed the House? previously passed the House as a veterans housing bill, now was a major health care restructure, and had not had a hearing in the committees of jurisdiction. The only hearing it had was here in the Rules Committee. I remember it very well because I brought 18 amendments to the table and laboriously went through them one by one. The Rules Committee at the time was very generous. Ranking Member Slaughter was the chairwoman of the committee, very generous, and allowed me all the time it took to plow through those amendments. Thanked me for showing up, and that was the last I ever saw of any of those amendments. But that was the only hearing that was had in the House of Representatives. So I recognize people can complain about process. I complain about process. But please don't comfort yourself that things were vastly better in 2009 and 2010 under all Democratic leadership in this body, because it wasn't. And in fact, many ways, we're doing the reverse of what you did during that process. You ended up with a reconciliation bill to fix some things that really needed fixing in H.R. 3590. You passed that, but again, no hearing in Energy and Commerce. I'm sure the Budget Committee at the time tackled something, but I don't recall an Energy and Commerce hearing on that. Look, the other thing that I do feel obligated to address is the issue of the CBO score. And I think, Ranking Member Pallone, you had referenced that there weren't any Republican published counters to the CBO score. Well, here's the bipartisan, Avik Roy, who works for the American Enterprise Institute, I think, and Doug Badger, writing in the National Review. Mr. Chairman, I'm going to submit these two op-eds for the record, but Mr.
And would please make a copy for the other members
I
that are on the
will give you
panel.
my personal
Thank
copy
you.
here in just a moment.
Thank you.
But Avik Roy, writing in the Wall Street Journal on the 21st of March, says, according to the CBO, able-bodied adults on Medicaid receive about $6,000 a year in government health insurance benefits. They pay no premiums and minimal co-pays. You'd think that eligible individuals would need no prodding to sign up for such a benefit. Sounds reasonable. And yet, furthering quoting here, and yet, according to its analysis of the replacement plan, the CBO believes that there are 5 million Americans who would not sign up for Medicaid if it weren't for Obamacare's individual mandate. So 5 million people need the threat of a $695 fine to sign up for a free program that offers them $6,000 worth of subsidized health insurance. Mr. Badger's comments are along those same lines. Mr. Chairman, I will make these available for the record, and I appreciate the consideration. Chairman Brady, the question was posed to you about did the Republican replacement, what was the effect on the Medicare Trust Fund? And there are some things out there that have been written. Here's one again from Avik Roy, quoting here. Speaker Pelosi admitted last year Democrats took a half a trillion dollars out of Medicare in their health care bill, and you can't improve Medicare's solvency by taking money out of the program. This was obviously some time ago that quote was collected. James Capretta, writing in the Weekly Standard, said the important story with respect to Medicare's finances isn't covered in all the trustees' report. That's the double counting of Medicare tax hikes and spending cuts in the ACA legislation. And then just to finish up, since the Heritage Foundation has been quoted and Robert Moffett has been brought into the discussion, his quote here, the Medicare payroll tax revenue is again double counted as paying for new spending and extending the life of the trust fund. So, and we had these hearings in our committee. I remember, Mr. Chairman, in the Energy and Commerce Committee, I think it was John Shimkus who got the information out of then Secretary Sebelius about the double counting of the trust fund, the 0.9% additional surcharge that is a working tax, a jobs tax that was, well, if it's necessary for the trust fund, okay, maybe that's one argument, but the money doesn't stay in the trust fund. It's pulled out to pay for other programs. Chairman Brady, since we're on this discussion, let me just ask you, and there has been a lot of discussion about, say the demographic that's between ages 50 and 64 and how they would be affected by the things that are present in the Republican plan. Can you offer us any insight on that?
Well, I can. So Chairman Black, in her remarks, talked about the bipartisan desire that we do all that we can to help those who are too young to retire, but in that 50 and early 60s age. I think one of the reasons there's bipartisan support is that Obamacare failed that population in spectacular ways. You may remember we were all promised, especially seniors, that if we could trick young people, or if Democrats could trick young people into paying far more for their health care than they really needed to, that the premiums for the 15, 16-year-olds would go down. Well, young people are smart, and they said thanks, but no thanks. And so the premiums for those 15, 60-year-olds skyrocketed. And they continue to skyrocket going forward in a plan that will collapse on itself. So they are in dire trouble today. So we address that three different ways. One, to ensure that states are able to develop plans that are targeted for those people who are, again, maybe early retirees, or they're like others, small business people who don't have health care like those workers at big businesses do. So one, plans tailored to their needs at that age in life. Secondly, because the stability fund, states are given dollars specifically to help low-income populations in that age group, and those with high medical costs also in that age group. And then in the manager's amendment, we take yet another step, provide more resources for them. In this case, we're proposing a step endorsed by the AARP to lower the threshold by which those who have high medical costs can deduct it from their taxes. We do it in two steps. First, a Martha McSally bill that lowers the Obamacare rate very high to 10% threshold down to 7.5%. We take it even lower to 5.8%. That is, as AARP points out, the population most likely to use that deduction. And in total, that is yet an additional $85 billion targeted toward that population. And we anticipate the Senate also taking this up and looking at either an enhanced tax credit or other approaches for that population. And so we've responded to the Budget Committee's recommendation to do specifically more for that population. Again, a group that is being punished, in my view, in a collapsing Obamacare.
Thank you, Chairman. And, yes, Mr. Palone.
Well, I understand what Chairman Brady is saying, but this impact in terms of deduction is very minimal compared to the larger problem that the CBO discusses with this group, and I'll be brief, which is these people from 50 to 64 are not going to be able to afford insurance, because even though they do get a tax credit, and it's a little higher for those that are younger, their subsidy is going to be reduced, is going to be eliminated, and this tax credit isn't going to make up for it. They're going to have, in many cases, $4,000, $5,000, $6,000 extra that they're going to have to pay, and many of these people are only making $30,000 a year. And in addition to that, they have this age rating that could go from 3 to 1 to 5 to 1 to 6 to 1. So between those two, a lot of them are going to lose their insurance, and this deduction that the chairman is talking about isn't going to make up for the difference. But CBO also points out that the effort to try to get more young people involved because of the difference in the age rating isn't going to succeed. Not that many more are going to sign up. So I don't think that this is really, this is kind of a failure, in my opinion, if that's what you're trying to accomplish. A lot of these people are going to lose their health insurance.
Mr. Burgess? Yeah. Dr. Burgess, it stands to reason, though, that any actuary could tell you that younger, healthier people are needed in the risk pool for the purpose of alleviating some of the costs that older people who are more likely to get sick are ready for. And I think that in this instance here, this was all taken into consideration. And you recall that one of the parts of the ACA that is conveniently left out of the argument is that these were negotiated positions that took place over months with specific industries that were vested in health care. And if I could tell you who was going to get sick and when, then we can address the issue in a different form. But the notion of shared risk is our reality.
Yes, Chairman.
Could I weigh in? Because remember, if all that works so well, then why would they be so far off in their count? Because the CBO said to do everything they've talked about, there'd be 20 million more people there on the exchange than there are. I mean, they're saying, no, I'm going to pay the penalty. I'm going to walk away and or get relief. And so 35% of those or 45% of those are under the age of 35. And so it's not working now. We're trying to adjust that a little bit or allow states to adjust that a little bit. Remember, we're giving this flexibility in the age band to the states. We set a minimum target, but we say it should be 5 to 1 because that's what the data all show it is. That's the reality of the market. But maybe that's too expensive. The states can go lower. They could go 4 to 1. Maine experimented in this with their sort of invisible risk pool and got fantastic results of more involvement. And so, I mean, there's an opportunity to be creative at the states. And so I know they think the states, they can put no faith in their states to do what's right for their constituents. I mean, we've heard that over and over. Don't trust the governors, can't trust the governors, can't trust the legislature. I came out of the legislature, and while I disagree with my governor from time to time, I think they come together and experiment and innovate and try and get it right. They have no incentive to get it wrong.
And Chairman Walden, one of the most, you usually don't use the words exciting and health policy together in a sentence, but one of the most exciting days in health policy that I've ever experienced was when our governors were in town in January, and you and I were at roundtables both on the Senate side and the House side, and the amount of energy and enthusiasm around those tables for people, governors, men and women who wanted to be part of the solution for the problems in their states. And I would just submit that there are differences, certainly differences between Massachusetts and Texas, as we're reminded about constantly, with our largest Republican delegation in the Congress and your all-Democratic delegation in the Congress. There are significant differences between the states, and the governors are some of the ones in the best position to be able to deal with that. Your governor's letter from Massachusetts, Governor Baker's letter, and he talks about the Commonwealth does have what he calls certain protections, and of course one of those is the mandate, the state-based mandate to buy insurance, and that is not changed in the Affordable Care Act. There is no federal preemption of a state requiring or putting a mandate on the purchase of health insurance, and I think, if I recall correctly, Paul Clement, who argued before the Supreme Court on the second day on the constitutionality question of the individual mandate, actually made the point that a state could provide a direction or a mandate for insurance, but that it was not the purview of the federal government to mandate that someone buy something and then put itself in the business of regulating it under the Commerce Clause. And I thought that really very eloquently. So there is nothing that prohibits Governor Baker or the state of Massachusetts from continuing their individual mandate that they have in the state. I think Chairman Walden did outline the very difficulties that Governor Baker had brought to us. I lost flexibility under the ACA, and I had to put people into the Medicaid program that previously were in our individual market. And one of the things he finishes up with in his letter is please provide us greater state flexibility with respect to health care. And we're going to talk about it in a minute since Chairman Walden already brought it up, but some of the things that are present in this bill that do provide for that state flexibility. And also, Mr. Chairman, I would like to, for the record, the letter from Secretary Price and Administrator Seema Verma to the governors on the flexibility provided under the 1115 waivers. And I know, Chairman Brady, this is important to our governor and our state. This is one of the things where I think the states really are crying for this flexibility, and they're crying for us to back it up at the federal level and not always cut them off at the knees. I'm sorry, I'll recognize the gentleman now.
Thank you, Doctor. I have this morning's headline from the Boston Globe, which says the U.S. health bill may hit Mass program hard. Baker foresees a $2 billion shortfall and 500,000 people at risk of losing coverage. I mean, the idea that Massachusetts would be penalized after having done all of these good things over the years is, I think, an imposition that the governor has acknowledged in the legislation that's being currently imposed or suggested to us to be voted on tomorrow. Isn't that the other part of the argument?
Again, your governors who came and talked to us, and your governor in particular, asked for additional state flexibility, and that is one of the things that is being provided in the legislation under consideration. Now, Mr. Walden referenced the Patient and State Stability Fund, which really, to me, is one of the most exciting aspects of what we are doing. Former Speaker Gingrich is fond of saying we can either be prison guards of the past or pioneers of the future, and here is the opportunity to be one of the pioneers of the future, to provide, again, states the flexibility and the resources to be innovative. And Mr. Chairman, I'm also going to ask to submit for the record Health Affairs blog that was written the first of this month on invisible high-risk pools, how Congress can lower premiums and deal with pre-existing conditions.
Objection.
With a very thoughtful article, and Chairman Walden, you already referenced the hybrid nature that they've done in the state of Maine. And make no mistake about it, Maine had done under a guaranteed issue prior to the Affordable Care Act, their individual market was in a death spiral. They admitted, 1993, they passed a guaranteed issue. Their premiums were up through the roof. Their pools, their populations were shrinking. Nobody was buying the insurance because it was too expensive. And they rescued their own individual market, not with federal dollars, which is actually a little bit intriguing, but with allowing the through a waiver process, a hybrid risk pool where, yes, there are risk pools, and then there's also reinsurance. They took 8 diagnostic categories. It'll be different for every state. Texas would likely be different from the 8 diagnostic categories that Maine selected. But of these 8 diagnostic categories, people weren't excluded from insurance. They weren't told they had to buy a special product, but their insurance was handled differently. The reason they refer to it as an invisible risk pool is because nobody had to elect to take it or not take. You were part of the individual market. You bought the insurance, one of the insurance policies that was available to you. Now, the insurance company that sold you that policy was committing to rebate 90% of that premium back to that invisible risk pool. Yes, there was a surcharge charged to the beneficiary. There was a per member per month charge of, I think, $3 or $4 a month. There were some additional monies from other locations. But the fact of the matter is they came up with a functioning hybrid reinsurance risk pool, and their premiums for people in the 25 to 35 age range went down by $5,000 a year. In the 60-year-old age range, it went down $7,000 a year. So yes, they did have to pay an additional premium of $48 or $50 a year, but the return on investment was indeed significant. I know, Chairman Walden, I know you've thought about this significantly. Do you have anything to add to that?
Well, I would just add, too, they adjusted their age band, too, their age ratio from 1.5 to 1, which is where they had it cranked down to. They went to 1 to 3. And that, coupled with the invisible risk pool, got it to where it worked. We're saying you'd have that ability. Right now, you're locked in at the 1 to 3, but somebody may want to go one way or the other to make it work for their population. Maine figured out they had it cranked down too far. And when they released it, it helped everybody. And then they had this invisible risk pool, as you say. And so when you couple that flexibility with the state patient and stability fund funding, and if you're in a non-expansion state, the money, like I referenced to my good friend, Judge Hastings, you're talking a lot of money states can now have flexibility to innovate with and actually bring down costs. And then you think about the second bucket, which we haven't talked about but been somewhat criticized for. Dr. Price, now Health and Human Services Secretary, has 1,400 different authorities under the Affordable Care Act where he can affect change in a positive way for the people we represent and for our states. He's told them, as you referenced in the letter, we're going to give you maximum flexibility. I go back to that example, Dr. Burgess, of Governor Herbert from Utah that pled with the federal regulator back here somewhere to be able to email with his Medicaid recipients by email who had email. He had snail mail backup for those who didn't, so there was a safety net there. 9 months later, CMS emails him to say no.
You can't use email.
He was emailed, and he told me that would have saved $6.3 million. That's just one example. So our meetings with the governors were so instructional. They all pled with us for more flexibility. Now, I haven't met a governor yet that wanted less money, though, from the federal government, so I respect that. But you know what, we need to allow them to innovate here, because we all want to take care of the same group of people and do it the best way possible.
And they will be accountable as we will be accountable.
Well, in fact,
there is an elective process that they go through as well.
That's right. And in fact, we require that if they were to take the block grant. I don't think many will take the basic block grant, but if they did, there's accountability there. There's some indication with they've asked us to allow them to do in a work option, a work requirement. By the way, that's what we have in the welfare programs, TANF. It's the same metric to help people out of poverty, help them get training, do the things that lift people out of poverty, so when they get a job, they don't necessarily lose their Medicaid. I mean, there are lots of flexibilities in here we want to give states to help people out of poverty. You know, we've just got to do better all the way around.
Well, I mean, just briefly, though, look, the numbers don't add up. I mean, we're talking about a $100 billion fund that my chairman keeps referencing. I mean, you can divide that by 50 or however you want for the states. I guess it wouldn't be divided that way, but the bottom line is, you know, you're taking $880 billion out of Medicaid. This fund can't do all these things. It can't make up for the loss of all that Medicaid dollars. It can't make up for the loss of all the subsidies to the seniors and to others. It can't make up for the age rating if it ends up going up to 5 or 6 to 1. I mean, it's nice to have this fund. I'm not suggesting it's a bad thing, but it's just the numbers just don't add up in terms of the cuts and the repeal of these taxes that we're paying for all these things that allow the Affordable Care Act to be successful. So I just don't think it's fair to suggest that somehow this money is going to make up for all the other things that we're losing to Medicaid and through these tax repeals. It just doesn't add up. The numbers don't add up.
Chairman Brady.
Well, I was just going to say, it added up in Wisconsin, where the governor took the Medicaid from 200 down to 100%, made a conscious effort, and was the first governor to cover all people in poverty, all people, up to 100%, and then did a private sector solution to help people buy planes for themselves who are working themselves off of Medicaid. And with less money, ended up with a lower uninsured rate than several of the states who took the expansion money. So Chairman Walden and Chairman Black's point that states are very creative, they're innovative, they know their constituents. They know how best to work them off of Medicaid and provide them affordable health care. What they also know is that Washington one-size-fits-all is not working.
Chairman, you brought up something that reminded me of you and I served, or actually I was just a humble backbencher, and you were the chairman of the vaunted Joint Economic Committee several years back. And, you know, it's almost like we're talking about this in a vacuum. We've got $20 trillion in debt. We're coming up on a debt limit discussion that is likely going to, eat the world. And we've had a problem in this country where our growth rate has been between 1% and 2%. If there were a growth rate that were in excess of 2%, many of these problems go away. Many jobs are created. Many people go to work. Many people have employer-sponsored health insurance and no longer need a federal program. So I think part of our focus also ought to be, how do we get the economy back in gear, which unfortunately has not happened. It's been the slowest recovery in a recession, I think, in forever. We were always told when I first got here that jobs are a lagging indicator during the Bush years and the Bush recovery back in 2003 and 2004, that jobs were a lagging indicator. Well, they're no longer a lagging indicator. It's actually growth in the GDP that's been the lagging indicator, and that is the wet blanket that is out there that is really underpinning all of this. If that problem can be fixed or at least improved, a lot of these other problems become much more manageable, which is why attention to our tax rates and tax policy are critically important for the things we have going forward. I'll allow the gentleman to respond, and then I'm going to yield back to the chairman.
Thank you, Doctor. So you're referencing the Clinton years with more balanced budgets?
No, I was actually referencing the years that I've been here, the last 8 years, we've had growth between 1% and 2%. Again, I will defer to experts who, if someone can provide me 2 successive quarters of greater than 2% growth, but I don't think it's happened. And if it were to average 2.4% or 2.8% or 3.1%, many of these problems become much more manageable. I know that because under Chairman Brady's tutelage on the Joint Economic Committee, that was my entire sum total of my economics education.
Mr. Burgess.
Thank you, Mr. Chairman. You've been very indulgent with the time, and I'm going to yield back.
Thank you very much. The gentleman from Colorado is now recognized.
Thank you. I'll yield to my friend from Massachusetts, Mr. McGovern.
Just a few quick points. I just wanted to make sure the record was clear. Mr. Brady invoked AARP in one of his answers, and I want to make sure the record is clear that the AARP is strongly, and I emphasize the word strongly, opposed to this underlying legislation.
Granted,
And-
but please be
and-
aware, I
and we
referenced
submitted
this
it, right.
in regard
But I don't want
to the
anyone to be
McSally bill that they strongly
right.
support.
But I don't want anyone to be
that is in
confused
this
that the
legislation.
I don't want anyone to be confused that the AARP in any way, shape, or form
And I know you
supports
don't
this,
wanna
supports
mislead
this bill.
people in this
The second thing, and I found it curious, Mr. Burgess's response to Mr. Neal's invoking our Republican governor's concerns in Massachusetts about hundreds of thousands of people losing health care. If I could cut through all the verbiage, basically the answer was, so what? It's easy for people sitting here, in this committee room to kind of disregard some of the concerns that many of our governors, many Republican governors have. But I'm going to tell you, none of us are going to have to pick up the phone and tell people they're losing their health insurance. And then the final thing is, how times have changed. Mr. Burgess, in 2010, you insisted that the Energy and I use the word insisted, that the Energy and Commerce Committee not mark up the Affordable Care Act without a CBO score. In fact, you made a point of asking, I quote, Mr. Chairman, will you commit that we will at least have a CBO score on the bill that we will mark up, end quote. Well, the lack of a CBO score for the updated bill here doesn't seem to bother you, so I guess things have changed. And then at the end of last year, you said, I'm confident that the new Congress will advance legislation through an open and inclusive process to empower states, patients, taxpayers, doctors, nurses, hospitals, and insurers to participate in discussions that so profoundly affect their lives. Well, governors, taxpayers, doctors, nurses, hospitals, most of them have all come out in opposition to your bill. They certainly have not been invited here to Washington to participate in any hearings, because there have been none on the underlying legislation. And so I don't know whether anybody here actually sought their input or whether we're ignoring it. But the bottom line is, I go back to process. The way you are bringing this to the floor with so little input from people who are directly impacted and people who know a lot more about this stuff than all of us sitting around this in this room here today, I think is astonishing. And I think I think if this sees the light of day, I think my friends here are going to live to regret it, because this is a bad, bad bill. 24 million people losing their health insurance, millions more losing health care protections. This is unconscionable. I thank the gentleman for yielding me.
Could I just?
I'll be happy to yield to the gentleman from New
The other
Jersey.
thing is, Dr. Burgess's whole idea with growth, growth of jobs, growth of the economy. Bottom line is, when we put this bill together, the people that are in this Medicaid expansion population, or even those in Medicaid as well, I mean, they're working in jobs that, are low-paying jobs, sometimes 2 or 3 jobs. They don't get health insurance. And I don't see this scenario that he's painting whereby, the economy grows and all of a sudden they're going to be much higher paying jobs that are going to provide health insurance. I mean, these are working people. We got to get away from the myth that these are people that don't work. I mean, some are disabled, some can't work, but most of them overwhelmingly are
along
working.
those lines, Mr. Pallone, it seems like under this Republican bill, since one of the groups that the tax credits don't nearly cover the equivalent of the subsidy today on the Affordable Care Act, are folks that are earning more than enough to qualify under Medicaid. Let's say, depending on the size of their family, it could be $40,000, $50,000, $60,000 a year. These are the folks that we're talking about. But my question is, in many cases, since they're losing the subsidy, the refundable tax credit is just a small portion of what that would be for them. Aren't many of them going to have to choose, basically, some of them have to choose to quit their jobs or to go to work at a minimum wage job instead of a $40,000 a year job so they qualify for Medicaid again. Isn't that what some of them might have to do?
Absolutely. I don't see how what this Republican bill accomplishes in any way encourages people to work or makes it easier for them to get a job that's going to, where the employer is providing health insurance. I think that's a myth. I mean, again, we were responding, 7 years ago to the realities of, what people face. And the fact of the matter is that many people who don't have health insurance, most people who don't have health insurance then, were people that were working, but they didn't get health insurance on the job. And, if you want to create an incentive for employers to provide health insurance, well, maybe you can, provide some sort of additional help to them. But to suggest that, somehow this bill is going to make a difference in that regard, I don't see it. I think these people just lose their insurance because they're either going to be kicked off Medicaid or they're not going to have enough of a subsidy.
And in that case, their only answer is actually to quit work, or if they're earning $40,000 a year, maybe to earn $30,000 instead, quit their job and take a lower paying job.
Could very well be the case.
And because of the Medicaid. So I wanted to start with couple Ways and Means related questions. I wanted to ask the chair and the ranking member if the refundable tax credits are in fact a new entitlement.
No. In the sense that today, the health care subsidy that you receive at work and other Americans receive at work, which is the largest part of our tax code, biggest break, it's only available if you are in a group plan, like in a big business. For the first time, we transform that help to that small business person, to that worker who's in a small business, to that mom working herself off of Medicaid, to make sure that they can buy health care affordable to them.
Well, if we
so
can just
that equal treatment of health care in the tax code is now unlocked and available to more Americans.
Well, on the refundable, tax credit side, and whether it's an entitlement, I mean, I think one yardstick we would use to say, is this an entitlement, is does it go through the annual appropriations process, or is it handled by your committee? And is this refundable tax credit handled by your committee or part of the annual appropriations process?
Yeah, it is based on eligibility.
Okay.
And is part of the mandatory spending.
And I would go to Mr. Neal, but to me, that sounds like what we call entitlements here. Mr. Neal?
It's less generous. I think that's an important
Yes.
consideration. And the second thing is it's a fixed allocation.
Okay. In the aggregate? It's a fixed allocation in the aggregate, but it's administered by your committee.
Unless it
not-
goes back to the committee
No, it's not a
down the
fixed.
road, isn't it? I think it's a fixed allocation. You can
No.
only use, it comes as part of the notion of the block granted
No.
allocation.
If we have more
On the
people, I
tax
guess that's a
credit.
good, so if there's more people in the country, this would in effect cost taxpayers more if more people got it?
No, this is a credit based on age that grows as you increase in age, grows as your family expands. And so that is how it
But
operates.
it's less generous.
Right. And I know that there have been several of our colleagues, Jim Jordan of Ohio has called this quote-unquote a new entitlement. I have another quote from Freedom Partners that says that this is in fact a new entitlement. The legislation simply swaps one federal entitlement program for another. And again, it's certainly my understanding of that word that those are formulaic, if you will, expenditures that are handled by the Ways and Means Committee, not subject to the annual appropriations process. So I guess I would ask the chair again, how does that differ from, what my understanding of entitlement is?
Well, I know it differs dramatically from Obamacare.
Yes, there's
Very-
different,
yeah,
again, I don't,
thank you for
again, you could say that has entitlements too. I don't think anybody would disagree, but it seems like your bill has
It
entitlement.
differs not just in title or description, it differs in so many ways. It is not means tested, it doesn't discourage work. It's really focused on growing as your age increases because you usually use more health care. Growing as your family expands, we make sure it covers the coverage gaps within Obamacare that exist today. And thankfully, it doesn't chase higher and higher premiums. So overall, it helps over time contain the cost of health.
It sounds like you're using family size and age as the basis of the entitlement instead of income level. That is what kind of the shift that would be occurring with this bill?
That is a key difference in this.
Mr. Neal?
To my knowledge, it does not discourage work, Mr. Polis.
Which one?
The whole idea of the credit, it doesn't discourage work.
Well, what about, I mean, again, I think it does, because I heard from a constituent that is currently able to afford health care through the exchange because of a subsidy. They're not Medicaid eligible, they're a little bit above that. It's a very low level. In a district like mine, middle high income, I mean, you know, you have to be very low income to get Medicaid. So they're above that level, and he needs monthly injections for carcinoma to prevent you know, future, several $1,000s a month of treatment. He has to have insurance. He, in effect, would need to quit his job and go work at a minimum wage job if it seems like if this were, or quit his job altogether, and I guess try to get disability or whatever he could, get a reverse mortgage on his home or something. But he would not be able to work at that job that he currently earns in the mid-40s or low 50s.
Not under the Republican plan.
Mr. Neal?
But my additional argument there would be that's the purpose of us expanding the earned income tax credit. There are a series of things that you can do to try to make some of those adjustments, but I don't see the evidence, to be honest, that it discourages work. I've not heard that one before.
Which one?
Your previous statement.
The Republican bill?
No, the idea of using a tax credit, I'm not aware of that discouraging work.
Well, the fact that currently, under Affordable Care Act, the amount of the subsidy is related to the amount of income of somebody. So he gets a higher subsidy because he earns $45,000 a year than somebody who earns $75,000 a year. With that higher subsidy, he's able to afford a health insurance plan.
But for the first time, I think it's in the manager's amendment, for the first time, they are offering minimum work requirements under Medicaid. That's
Well, yeah.
But that's separate from the issue.
And that's separate. Look, most people who have Medicaid either work or want to work. I have some concerns in areas that might have 20% unemployment about that. In my area, that's not a great concern because people work. But the question, the problem I'm having is people will actually have to earn less or cut back. You know, I mean, literally, he'll have to quit a professional job to work a lower wage job if he wants to get coverage.
I think the point you're making, and I totally agree with you, is that because the ACA has taken this population that was a little above Medicaid in its income, or above that, they needed a 70% or whatever subsidy. Now we have created a situation where these people in that, you know, 25 to 40,000 income, whatever, basically can work and know that they're going to have health insurance.
Right.
You start chipping away at that, and then they lose their insurance, they can't work, they kind of look for a different job. I think you're absolutely right.
And the driver of that is because this new entitlement program, as the chairman said, replaces the income level with age and size of family as the criteria. So under this proposal, a constituent earning $120,000 who currently gets no subsidy on the exchange would in fact get a refundable tax credit. But my constituent making $45,000 would receive much less.
No.
The refundable,
I'm sorry.
Would the refundable tax credit be less than his current subsidy in the exchange for somebody making about $45,000, $50,000 a year?
I will tell you, this isn't based on income. It's based on age and family size.
Well, right.
And so it's available if you're making $16,000.
Same, that's exactly what I'm saying. I think we're saying the same
Or if
thing.
you're making, as a family, $100,000.
No, we're saying exactly the same thing.
So it doesn't discourage work at all. In fact,
Well, it does.
For small businesses, no. If you, as you earn more money, if you got less, if your means test all the way through, that would be the case. But this is a age-related and family size tax credit that you can use in a small business, in between jobs, if you retire early, if you're that student who's 27 or 28 and working toward that first job, all eligible for that.
Yeah,
So
no,
it actually encourages work, in my view.
Well, again, having heard from this constituent, I mean, again, the situation is simply healthcare is either affordable or it's not, given your budget. You have home payments and rent, you have food, you have stuff you have to do.
But, you know, for that constituent, just so you know, because the work that Good Work Energy and Commerce did, each state is getting billions of dollars to actually help that person who has a very high medical cost that you want to help directly so that it doesn't drive up the premiums for others in that area.
Well,
But again, you're going to be cutting back on the money that goes to the states from Medicaid. They're not going to have the subsidy. There's no way that that
Well, this
fund-
person isn't in Medicaid, as
No,
Mr.
I
Polis
understand, but
described.
I'm
Because of the subsidy in the exchange,
let's
he's able to
stop
get
changing
coverage.
people.
Yeah,
He will
and-
not be able to get coverage without the subsidy
Right,
level
and
that he
that
currently
fund isn't
gets.
going to make up for it. It doesn't have enough
Oh.
money.
Colorado would get $351 next year out of this fund.
Right, but how much are they going to lose,
Yeah,
those
and-
individuals,
and I have to
to
tell you-
Medicaid and their subsidy?
Colorado is a great example. This is one of the states where nearly 4 out of 5 Coloradans who are forced to buy Obamacare in the exchanges and get generous subsidies have figured out a way to exempt themselves. 4 out
I'm
of
sorry,
5
say that,
people,
who exempt-
4 out of 5 people in
Yeah.
Colorado
Jim, yield.
who are
Excuse
eligible
me,
for
just a moment, please.
Obamacare.
Mr. Chairman, excuse
Yes,
just
sir.
a moment, please.
I'm happy to yield to the chair.
We need to see if we can allow you to finish your question. We'll put you on hold. We need to go vote.
Okay,
Trying not to delay what is on the floor. I will allow you to continue your questioning, but you control the time.
Oh, how much time remains on the vote? 0. Oh, okay, well, we better, we better.
Thank you. Subject to the call of the chair, after the last vote, we will begin. Thank you very much, and the gentleman from Colorado will control the time.
about that.